دكتور وائل سامعني؟
ايوه سامعك، انا دلوقتي بس بظبط الشير.
طيب ماشي اوكي.
كده انت شايفني فول سكرين مش كده؟
كده شايفها فول سكرين
تمام. مساء الخير يا جماعه. النهارده طبعا بنشكر الدكتور توفيق على الفرصه الظريفه. I would like to thank Dr. Tawfiq for this lovely chance, and I would like to effort conducting for organizing. It's been a very stressful time. We're all confined to the tip of the phaco, and then the aspiration line that goes into the pump and then into a drain. So basically, this is your phaco machine, and these are the parts that you need to know about. The other part that you should be concerned of is the foot switch. The foot switch has 3 stages. The first stage is the irrigation, when you open the irrigation bottle. The second stage, when you press further, you start activating the pump and activating the aspiration. And the third stage, when you start activating the handpiece and you get the phaco pump. Phaco pumps, there are several types of phaco pumps. The legacy machine, when we first started, we could even easily see, this is the first phaco machine that I've ever practiced on. You can see the peristaltic pump. What's the meaning of the word peristaltic pump? peristaltic pump, when you have a peristaltic movement or a drum that is circulating with the rollers that milk the fluid to one direction. So it's milking the fluid out of the eye and into the drainage chamber. Then came the infinity machine, and it started using exactly the same peristaltic pump, but with different modes and different fluidics, and using what we call the FMS, or the fluidics management system. And as you can see, the tubings has changed. It became more firm, and we have the rotors of the FMS is applied into this part of the machine, and then you have rotors that turns around and squeeze the fluids in here, and then you have sensors and you have other parts of the fluid management system. Then came the new machine, the Centurion, and this machine is different, where you can have a dual segment pump to enhance more stability and more consistent peristaltic movement. The rotary valves, we have two rotary valves. The rotary valve is here, and then we have the dual pressure sensors here. And we have the multi-point FMS calibration. You have a calibration that goes all the time. And also the tubings became much more firm to prevent the surge. And we got also what we call an increase in the number of the rotors here. It was 4 in infinity, and now it's 7. So you have more stability in the peristaltic pump. You have more control, and we were introduced also with the activation, and this is where you can see the FMS system, where it applies into the part in the machine. Here, I would like to show you where when the idea is the firm or not firm tubings. When we used to, in the old machines, when we used to have occlusion, sometimes the tubings collapse. When the tubings collapse, that means that when you release your foot to stop the vacuum, for the tubings to go back to their normal position, it means fluid is still going on into the eye. So when you break the occlusion and you stop your foot from the pedal, you still have fluid going into the tip of the phaco, and if you're about to engage the posterior capsule or the iris, you will fail to stop in the right time, and you will have the problem of surge, or you can injure the posterior capsule or the iris. To overcome this problem, many systems have developed various methods. One of them is the vent valve. There are two types of venting. The venting with fluid, venting with air. And this is in your concern when you're buying a machine. It's not a big deal to be concerned about right now, but you should know that the fluid venting is better than the air venting, because air is compliant with pressure. You get more pressure, or with pressure it collapses. With less pressure it does not collapse. Is my screen clear? Okay, I can see everybody see. All right. The next pump, famous pump, is the Venturi pump. The Venturi pump has a problem. That it's a very good machine for vitrectomy, but it's not suited for phaco, because you cannot disengage the aspiration rate from the vacuum. It's a vacuum-based pump, unlike the peristaltic pump, which is a flow rate pump. So you cannot dissociate the vacuum from the flow rate. you have a constant vacuum all the time, even with no occlusion. So it's very good for vitrectomy. For phaco, it needs a very experienced surgeon, and it gives high risk of engaging any of the AC content. Then you have the diaphragmatic pump, you have the scroll pump, and you have the rotary pump, and these are not very famous pumps to use, so we're not going to discuss them at all. Now we're going to talk about the aspiration flow rate versus the vacuum. So what is the aspiration rate? It's a very important question that you should always know the answer for it. The aspiration rate is the rate of fluid leaving the eye. Many people would confuse it with the rate of fluid entering the eye. Actually, in a normal, smoothly going on surgery, it should be the amount of fluid going on inside the eye, because it's equal to the amount of fluid going out of the eye. But if your irrigating bottle gets empty for whatever reason and you don't notice it, the flow rate is still going to be active. So the eye will collapse. So the flow rate is not the amount of fluid going into the eye, it's the amount of fluid. What pump, okay? So what specifically in the pump, it's the rate of rotation of the pump. So if my pump is rotating very fast, this means that if this pump is rotating very fast, it means I have a very fast flow rate. If it's rotating slowly, it means that I have a very slow. If it's slow, then it's a slow flow rate. If it's slow, then it's rotating slowly. If it's fast, then the flow rate is fast. Okay, so this is the aspiration rate. What about the vacuum? Vacuum is the negative pressure built inside the tubes when you have occlusion. So the vacuum is preset. If you set your vacuum to 200, negative 200, when all the tubings are, when the tube is not occluded, you don't have that vacuum. You will have a vacuum that's equal to the resistance of the fluids going into the eye. It's not, going into the handpiece and the fingertip, and the resistance of the fluids inside the tubes, but you're not going to have like a real vacuum activated. It's going to be around from the 0 to 20s or 30s, depending on the viscosity of the fluid. Okay, when you have occlusion, you will reach the preset vacuum that you've preset in the machine. So if you preset your vacuum to 200, if you get full occlusion, and you keep pressing the foot switch, you will get the 200. If you preset to 400, then you will get to the 400. Okay, now I want to understand the relation between the flow rate or the aspiration rate and the vacuum. If you have a very fast flow rate, so you're having the pump is rotating, okay? The pump is rotating very fast. Oh, let me go back to the vacuum. Once you reach the 200, the preset vacuum, let's say it's the 200, your pump will stop rotating. Your pump will stop rotating. So the pump will keep rotating until the negative pressure inside the tubings is the preset negative pressure that you put, let's say negative 200, and then the pump will stop. Not rotate anymore, because if it does, the vacuum pressure will go higher. So it will go more negative pressure, it will be minus 400 or something. So what's the relation between the aspiration rate and the vacuum? If you have a very slow aspiration rate, it means that your vacuum is building slow. It means that your rotation is slow, so your vacuum is building slow. If you have a very fast aspiration rate or flow rate, it means that the pump is rotating quickly, and that means once you engage something and you occlude the tip, your negative will rise very quickly and reach pressure. So this is a very important. So the higher the flow rate, the quicker the rise time to reach your preset vacuum. So if you are afraid that you will get engaged, if you're afraid to engage the posterior capsule, you should do you should lower your aspiration rate. If you're facing surge, every time you break the occlusion, you get a surge in the anterior chamber. That means that you need to lower your aspiration rate. The next thing about the fluidics is how the fluid flows inside the anterior chamber. Here we have the phaco-tip placed in the optimal central zone. So you have the aspiration in the anterior half, you have the irrigation in the posterior half, not in it's the yeah, what I mean is the other half. So the fluid is coming out from the irrigating ports. less, and because it has a smaller bore inside here, so you can bury it into something and then get a good holdability. And it fragments on two levels. So when you are fragmenting, you fragment on this level, and then you fragment also on this level. So it has two levels of fragmenting power. Then the ABS tip. The ABS is the aspiration bypass system. This is when you have a small hole in the tip where fluid bypasses the block. The phaco tip is occluded. You bypass the occlusion by letting fluid from this opening, which gives you more cooling to the phaco tip, which gives you wound is better to avoid wound burn. And it also, when the occlusion is broken, when you break the occlusion, you still have fluid has already been going on, so it gives you less surge. There are other types of tips, like the Barrett microflow tip and the Cobra tip and the diaphragmatic. Each one has its advantages and disadvantages. The Barrett has grooves on the surface, so it allows more cooling. The Cobra has a very big anterior tip. The diaphragmatic has a constriction inside it to lessen the surge. So each one has an advantage and a disadvantage, but they're not commonly used. This is the most commonly used tip when you open your phaco fluid management system. You find your tips, and this is what tells you all the advantages are in one tip. So you have a Kilman, it's a bent tip. You have a mini tip, and it's flared, and it has the ABS. So it has all the advantages, and it combines all the types: Kilman, mini, flared, ABS tip. Okay, now we shift to talking about power and stroke. What is the stroke distance? The stroke distance is the distance that the phaco tip covers moving forward and backwards. So the stroke distance is the distance that the phaco tip vibrates into. So if it's vibrating forward and backwards, let's, for example, say it's moving in a 500 microns. It moves forward and backwards in a 500 micron distance. This is only for an example. So what is the power? If the stroke distance is the movement forward, the power is the percentage of this distance. So if you say I'm using 30% power, it means you are using 30% of those 500 microns, which will give you around 150 microns movement. So you are only vibrating 150 microns. But if you use 50% or 60% power, it means you are moving in a longer distance now. Now your tip is going backward and forward, but in a longer movement, which means it's a more violent movement. The frequency of your machine does not change, but the power means it's the percentage of the stroke distance. This can change. So the distance covered changes. So you should put in mind, when you're using a low power, your vibration forward and backward is in a small distance. But if you're using a higher power, you're going forward and backwards in a very long distance, and that's very violent, and that sometimes leads to repulsion of your phaco fragments. But what happens in torsional phaco? In torsional phaco, the movement is supposed to be a torsional movement. The fluid tip is moving around itself here. So that's translated when the tip is bent, that's translated into a swinging movement. So this swinging movement still has a stroke distance, which is the distance that it rotates itself, which becomes the swinging movement. So if you're using 30%, you're swinging 30% of your total swing distance. And if you're using 60%, It means that you are using 60% of the swinging distance. Just 1 second. Okay. All right. So cavitation. Now we're going to get introduced to terminologies inside the phaco process. Cavitation is the process of fragmenting the cortical matter or the nucleus itself. So you have the cavitation bubbles. When the phaco tip is vibrating ultrasonically, you start getting cavitation bubbles and cavitation fragments, and the irrigation fluid is going in to clear up those debris. This is what you see when you can see a cloud of foam or a cloud of foamy white material that appears in front of you when you're sculpting or fragmenting the nucleus. And this is a good sign. It tells you that you are using the optimal power. You're not using too little power and you're not using too much power. So cavitation is a good thing. Now we go into the phaco modes. Now we're going to be discussing the phaco modes. We have 3 types of phaco modes. We have the continuous mode, and we have the pulse mode, and we have the burst mode. The continuous mode is when you have the phaco tip vibrating continuously. When you press your 3rd stage pedal, you have the phaco tip vibrating continuously. The pulse mode means that the phaco tip will vibrate in pulses. It will give you a pulse and then stop, give you an interval, stopping in an interval, and then vibrate again. This graph, sorry, I see okay, this graph shows you how it looks like. This is a continuous phaco. So it's constantly vibrating. This is a phaco pulse, where it gives you a pulse and then it stops, a pulse and it stops. And this is the burst. The burst is different, that it has both, it can reach both, it combines both the continuous and the pulses. So if you're in the continuous part, if you use, let's go deeper with the next slide so you can see so this is the continuous. The continuous mode, it's either panel controlled or surgeon controlled. Panel controlled, if it's panel controlled, once you reach the 3rd stage of your foot switch, it means it will give you the full preset power of the phaco. If your preset is 60%, it will give you 60% constantly, non-stop, and it doesn't change. But if you are surgeon control, it means that when you reach the 3rd stage, it would start its continuous mode, but the phaco power will start at 10, and then 20, and then 30, and then it will reach 60 by the end of the distance of your foot pedal. So this is surgeon control, and this is panel control. Now you can call this is a fixed mode, and this is a longitudinal mode or variable mode. When you come to the pulse mode is, you can see that the intervals is fixed and the pulses are fixed. So each pulse duration is fixed and each interval between the pulses is fixed. When you press, if it's surgeon control, as in this one, the more you press your foot pedal, the higher the power that you can reach, but still the pulses the frequency of the pulses is the same and the intervals are the same. The distance between the pulses are the same and the duration of each pulse is the same. But you can change your pulse duration and you can change the interval duration. So if you increase the frequency of the pulses, if you say like I want 2 pulses per second, you have this one, you get 1 pulse, stop, 1 pulse, stop. But if you say I want 10 pulses per second, you get one pulse, stop, second pulse, stop, and so on. Eventually, if this is 50% on and 50% off, this is 50% on and 50% off, eventually both of them will give you the same amount of deliver, because it's 50% of the time on, 50% of the time off, and it's the same here. But it will give you more pulses. And this is good for holdability. Pulse system or pulse mode is good for holdability because it gives you a chance to fragment and then hold. Fragment and then hold. It gives the vacuum a chance to hold the nucleus fragments into the phaco tip, and then fragment and then hold it back. It gives less repulsion and good followability. The duty cycle, this is a very complicated expression that a lot of people get confused about. The duty cycle is the relation between the on and off. You have 50% on, 50% off. This is your duty cycle is 50% on and 50% off. And it's the same. This is the same drawing that we have seen in the previous slide. But you can change your duty cycle. Changing the duty cycle will change the amount of phaco delivered. So this is a 50% duty cycle, but this is a 20% duty cycle. So now you have 20% of the time on and 80% of the time off. This gives you less phaco power, less heating, and better holdability. So if you're worried about wind burn, or you're worried about your holdability, you can decrease the duty cycle. There are other modes that change in the duty cycle to conserve energy also, which is changing the mode of delivering the power. You can have a slope, like a rising power, and then you reach the full power of the pulse. And this conserves energy and gives you less heating and better holdability. These are two systems of using the duty cycle. Now we have the cold phaco. We will discuss the cold phaco. Phaco, continuous phaco produces heat. And this is how you see when the phaco tip starts vibrating, first it's cold, and then it becomes warm, and then it becomes very hot. And the more you use continuous power, the more heat it generates. It generates heat. So when we're using the traditional pulse ultrasound, first it was hot, and then warm, and now it's hot. Then it cools a little bit, but it stays warm, and then it gets hot. And when you use more power or like longer times of the pulses, then your pulses will become all hot. When the white star technology started, and this is hyperpulse mode, it gives you very short pulse that doesn't give chance for the phaco tip to heat, and then gives an interval that allows for the phaco tip to cool, and you have a very high frequency of pulses with cooling of the tip, and you have what was called a cold phaco. Now the burst mode. The burst mode is designed to combine both the continuous and the pulsed mode, and to allow both panel control and surgeon control over phaco. So the panel control part is the amount of power. If you preset it on 60, once you reach the third part, it's delivering a 60% power. But it will give you a long interval. The more you press on the foot pedal, the intervals will get shorter. The intervals will get shorter. The intervals will get shorter and shorter and shorter until there is no interval. When you reach the end of your foot switch, the end of the travel of the foot switch, you get a continuous full power delivery of the phaco power. And this is the best mode that you can use to conserve power, to lessen the heat, and to go to efficient phaco. And it's the favorite mode when you're using the phaco chop technique. Now let's revise some terminology that we have already discussed right now. We have discussed the bottle height. The bottle height, we have to know that the bottle height controls the pressure inside the AC. So when you raise the bottle height, the pressure inside the eye is increased. When you lower your bottle height, the pressure inside the anterior chamber will decrease. So if you are having trouble with a myopic eye and you are facing the anterior chamber is too deep, it means the pressure inside the anterior chamber is very deep, is high, and it's causing a deep anterior chamber. So you lower your bottle. And when you lower your bottle, you are worried that the aspiration rate might be too fast for your irrigation bottle. So what you do in a myopic eye, you also decrease your flow rate a little bit if you are worried about the surge. But if you don't lower your bottle, you can also increase your flow rate, and that will give you a shallower AC. But this needs a very experienced surgeon that can deal with high flow rates. Some surgeons can function with very high flow rates, and they can, with their experience, they can handle it. Others would prefer always to stay with low flow rate, because the flow rate controls the speed of things coming into your phaco tip, and the what we call the rise time of the vacuum. The flow aspiration rate, we have discussed the flow aspiration rate, which is controlled by the speed of the rotation of the peristaltic pump. The vacuum is the negative pressure that builds into your aspiration line after occlusion. And the rise time is the time needed to reach this vacuum after occlusion happens. Occlusion is when the tip is occluded with lens fragments or lens particles. The rise time is the time needed to rise from zero or no vacuum into a full vacuum, and that is dependent also on the flow rate. The power of the ultrasound, as we said, is the distance that the ultrasound is traveling and the percentage of this distance. Phaco 1 is usually the sculpting mode. We use it in the phaco sculpting. Quadrant mode. Usually in the sculpting we use the the continuous mode. We'll discuss this in a minute now. In quadrants, you use the pulse mode. In epinucleus, usually we use continuous mode. And then there's the IA, which is the aspiration for the vacuum of the cortex. Followability, as we said, is the ability of the phaco system to attract and hold objects inside the eye. Fragments of the lens inside always flowing inside the phaco tip. Surge is when there is a discrepancy between the amount of fluid going inside the phaco tip and amount of fluid going inside the eye. If there's a discrepancy, then you get the surge. Cavitation is the fragmentation of phaco lens material. Shutter is what we said in continuous mode. If you're using a very high power, you'll get repulsion of phaco lens fragments from the phaco tip. The load is the amount of pressure used to pull lens fragments from inside the bag and getting it out. If it's a big particle of the lens, then you are using a high load, and this is the load on the zonules. So you should always tackle small sized lens particles. Duty cycle we've discussed is the on and off parts of the pulse mode. The stroke is the stroke distance. The frequency is the frequency of the vibration of the lens of the phaco tip. And these are two modes, comparison between two systems. We're not going to discuss this right now because we are running out of time. I would like also to discuss the interface. So this is the interface of the Infinity machine. This lecture was based on the Infinity machine, and it's also it has been modified to the Centurion also now. So this is the irrigation. This is what controls the height of the bottle. So it controls the pressure inside the eye. This is the vacuum, and this is what controls the vacuum, which is the preset from 90 here. This is the aspiration rate. It controls the speed, which is the rotation of the pump. We have here the phaco power, the longitudinal phaco power, the torsional phaco power. Green sign, horizontal, it means that this is fixed. This is panel controlled. So once you press, you will reach the 0 or the 60 or whatever. This is 90 is longitudinal. So when you reach the third stage, the more you press, the higher the power till you reach the 90. Here, the flow rate is fixed. If it's not horizontal, if it's beveled like this, it means that it's surging control. But here it's panel control. We can see here all my settings. Control, surging control, surging control, surging control. We're dealing with the quadrant, so we are using a pulsed phaco. We can have the limit. The limit here is 70. The pulse is 60% of the time on, and 40% will be off. The vacuum limit is 400, and the aspiration rate is 300. I'm trying to wrap up because I'm running out of time. Here, as we can see, we have also panel control, surgeon control, surgeon control, surgeon control. Now we can see the interface on the Centurion machine. There's a little bit of differences here because we can use what we call active irrigation. The active irrigation is, you don't use a bottle height here, but we open this chamber and we use a saline bag, and we have an active irrigation where you insert active FMS. So where the irrigation is done actively by controlled pressure from the machine, and it's not dependent on the height of the bottle. And because of that, patient eye level has become more critical. So you would have, there are lights that show up here, and you can control where the head of the patient, and you control where you can set your machine to identify the level of your the eye of the patient. You can get more control of the intraocular pressure at the 3 phases. You can get the vacuum also in 2 phases. You can control it either it's panel control or surgeon control. The aspiration rate also. This is longitudinal phaco, and this is surgeon control. As you can see, it's beveled. So this is your interface, and it's telling you that this is a continuous one, and we're doing the sculpting with it. And then you go for the quadrants, the cortex, each setting. And this is how your machine would look like when you're setting it. Now I'm going to talk quickly about the modes that I would use with each and every stage of my surgery. I hope I was clear at the previous knowledges, previous information that I've introduced. Now, if you're using sculpting, the objective of your sculpting is you want no holding. You don't want to hold the nucleus. You want to use minimal power. You want to use the least stress on the venules, and you want to clear the debris from the anterior chamber. So that makes you use vacuum. It's either panel control or surgical control. You can use panel control in this one, and the vacuum is usually between 30 to 50. You don't want very high vacuum because you don't want to hold anything, but you just want enough vacuum to help the aspiration flow rate clear the anterior chamber. So the aspiration rate, what you want is a low aspiration rate just to clear the debris from 12 to 20, and you want phaco as a continuous phaco. You can use torsional, or you can use longitudinal. Torsional is more your phaco because it preserves, takes less power and preserves your energy. You can use surgeon control or you can use panel control. Better use surgeon control, and so you wouldn't allow too much power and control your feet. In the quadrants, your goals are different. Now you want to have a good hold of your lens fragments. Now you want to use minimal power also. You want to produce least heat production, and you want good followability and holdability. So now your vacuum is going to go higher from 200 to 400, and it's going to be surgeon control. You don't want that vacuum to be too high if you don't need it, but you want to be holding very well. The aspiration rate is surgeon control also, and it can be range from 20 to 30 millimeters per minute. But the phaco power now is going to be pulse. You're going to turn into pulse because the pulse will allow you to do good holdability with least power and least heat production. And you can use torsional phaco for this purpose because it allows good fragmentation, and it's surgeon control. You can use surgeon control phaco. After you finish, you go to epinucleus. Epinucleus, your objective here is followability, minimal power, and minimal surge. So you will use vacuum, a surgeon controlled vacuum from 200 to 400. Use the least, it's better. 200 is good. Flow rate, it's from 25 to 30, and you should be very careful with that because you don't want to engage the posterior capsule. And at the end of it, you can use lower flow rate. And the phaco power, you use pulsed, it's good for you, but you will use longitudinal. I prefer to use longitudinal because longitudinal phaco is more forgiving if it touches the posterior capsule, because a torsional phaco will do a ripping movement once it touches the posterior capsule, and this will give you, this will rend the posterior capsule. Longitudinal phaco will tear into the posterior capsule, but it's more forgiving. It's more forgiving when it comes to longitudinal phaco. And you use surgeon control. I'm not telling you that the longitudinal will not tear the posterior capsule. It will tear the posterior capsule, but it's more forgiving. If you lift your leg in the right time, it can be forgiving. Now, if you're using direct chop, your objective is different from the other setting. You want good hold, you want minimal power, you want least heat production, and you want very good followability, and the most important part is good hold. So what will you do? You will use a very high vacuum, which is better panel control. Better use panel controlled, so you don't have to, when you lift your leg and you use from the power of phaco, and you go back to vacuum, you don't lose your vacuum. So you get panel control, but you can use surgeon control also. Flow rate, you can use a high flow rate from 30 to 20, no problem. And it's better to be panel controlled also. In the phaco, the most famous mode used in direct chop is the burst mode. It will give you good burying, so you can use longitudinal to bury yourself, continuous to bury yourself in, and then you can pulse to get a good hold, and then you go back to your vacuum, your full vacuum again. And you will use longitudinal phaco, not torsional phaco. Why? Because torsional phaco will make a hole, will dig a hole inside the nucleus that is bigger than the size of the phaco tip. The phaco tip is shaking left and right, so it will make a hole that is bigger than the actual size of the phaco tip. But if you use longitudinal, it will be tightly, snugly holding the nucleus, and you can do your chop technique with it. And it's a surgeon control mode because it's a burst. So these settings, I don't want you to think that these are the settings that you use with all your surgeries. These are just recommended settings that makes you orientated with how you should set your machine when it comes to dealing with phaco and with the variant stages and variant techniques. So the settings, these are not fixed settings. You can change with each patient and each stage, and each surgeon will be more comfortable with different settings. There's no right and wrong settings. But these are the settings that I would recommend and I would use with my patients. To sum up, today we have talked about the phaco parts of the parts of the phaco machine. We have talked about some critical details about each part and how it works. We have talked about the fluidics dynamics of the phaco machine and the phaco dynamics. We have talked about the machine interface and the controls, how we control our phaco. And we have talked about the various phaco modes and the types of phaco used. And we talked about when to implement those phaco modes and those types. And I think that's wrapped up now. I wish that we could go back to taking pictures like this. This is a live picture from Adi. I hope that my lecture was not too redundant, was not too long. I don't know if I think, yes, I think I've done it in a nick of time. And remember that the invention of the light bulb did not come from the continuous improvement of a candle. We have to always invent something new. And thanks to the coronavirus that brought us together. Thank you, Dr. Tawfiq, for a lovely gathering. And I hope that my lecture was beneficial. Now we can take quick questions if we have time. I don't think we have time.
We have 5 minutes, Dr. Wade, and we can take question for 5 minutes. Okay. Thank you very much for your presentation. It's very nice presentation. Thank you very much.
Thank you. Okay, I'll try to check the questions.
Seem to be no question, Dr. Wade. كله فاهم المحاضرة بشكل جامد جدا. Everyone is
no. If anybody wants to ask anything, they can raise their hand, please, quickly. Okay, I'll get to Dr.
Hips better.
I unmuted you. You can unmute yourself. Dr. Heba is not with us, so I'll try Dr. Maha. Yes, Dr. Maha.
Thank you so much, Doctor, for the lecture. I would like to ask about the myopia patients.
Okay.
So you said in order to control the AC depth, you have to lessen the bottle height and to decrease the fluid rate. Is this a rule for every myopic patient?
No, that's as I told you, some surgeons would prefer to work with a higher flow rate. Some surgeons will keep the bottle high and increase the flow rate and use that discrepancy in the increased flow rate to lower the depth of the anterior chamber. As I told you, these are like certain recommendations that I would do, but it makes your life easier when you lower the bottle. So the anterior chamber is less deep, and because this is a phaco course, so I'm teaching people phaco. So I don't want you to lower the bottle height and then have a high flow rate and then engage the posterior capsule, and that would be a tragedy. So when you lower the bottle height, please also lower the flow rate so you wouldn't have a surge.
Thank you so much.
Barry.
السلام عليكم. لو سمحت دكتور وائل، ازاي احنا بنقيس الاماونت اوف فيكو باور ديليفرد انفينيتي اند انسنتري؟
ازاي بنقيس الفيكو باور في هي في البانل. انت بتفتح في البانل كده، في جزء من البانل بتطلع فيه الماتريكس كلها. if I can find this على I think the matrix, you get the matrix from the panel here. Get all the power. I'm trying to screen tab شوية. By the end of the surgery, you get all your metrics from this part. Do you see my mouse?
Yeah, yes.
Yes, you get your metrics all from this part.
Thank you.
Dr. Who else? Dr. Hiba, I will try one more time if you can unmute yourself if you want to ask a question. Dr. Mu'taz Anterior. Yes. This is the last question because I'm running out of time, sorry. I can't hear you, Dr. Mu'taz. Can you please raise your voice? Raise your voice, please. I can't hear you at all. Okay, Dr. Mu'taz, we really can't hear you, so I'm gonna skip to another question. I'm sorry, really sorry. Dr. Ihab, this is the last question, please.
Thank you, Tuel, for the excellent lecture. I'm asking about how to adjust the power on the burst mode.
How to adjust the power on the burst mode? You just raise the power. You raise the power on the burst mode. So if it's 50, 60, whatever. You change your FECO mode from here. This is continuous, and this is pulse. And you would go to burst. If you open the panel here, it will give you a drop menu that will go to burst, and then you adjust your power from here.
Yes, okay. I got it.
Thank you. Thank you. So I'm thanking everybody. I think I've exceeded my time. Thank you very much, Dr. Muhammad. I'm very happy to be with you. And I don't know if I was too quick in giving you this lecture, because this lecture usually takes 2 hours at least. So please, I'm sorry, I tried to give you everything. I didn't want to give it half of it only. So this is half of the course. This is the theoretical part of the course. And then there is the clinical part, or the surgical part. Thank you very much.
Thank you very much, Dr. Wael. You'll be with us for the next week and the next week and the next week, because Corona will stay longer time, okay? So you will be with us, and it's our honor to have you with us for this week's, the coming weeks, okay? Thank you very much again. It was very nice lectures, and it's our honor to have you with us. We will remind you that in the next week also, inshallah, we will have the 12 for continuing the second part of FECO course. Now, please, we will move to the second session. We will have the retina session. Please, again, stop your video, because this is a privacy. I can see a video of some of our colleagues. Please stop the video. Now we will start the second sessions. We will have retina symposium. I would like ask our panelist, Dr. Amin Marashi, to unmute yourself.
Okay, I'm online right now. I'm hearing you. I hope you are hearing me as well.
Yes, Dr. Hassan Bahrani. Dr. Hassan Bahrani, you are with us?
Hello?
Yes, I can.
Okay.
Dr. Farid White, you can hear me?
Yes. That's how it was in the scripture.
Yes, Dr. Muhammad Tawfiq.
I can hear you, Dr. Tawfiq.
My friend, my best bro, Dr. Tawfiq, Muhammad Tawfiq. Welcome.
Touch it to yourself. Can you see the lecture, Dr. Tawfiq?
Yes.
There are two, Dr. Muhammad.
Yes. Don't worry. Just a minute, Dr. Hassan. Just a minute. I would like to our panel, Mustafa Zubaydi. Mustafa, my friend, you can hear me?
Okay, you hear me? My voice here?
Yes.
Okay.
So,
okay, with you.
Yes. I would like to start our next sessions in this conference for today. We will have retina sessions. It's a symposium, a panel sessions in which, first of all, we will have brief lectures about 14 minutes presented by our colleague, Dr. Hassan Bahrani. He's a famous veteran surgeon in Iraq, and he will present lectures. Actually, Dr. Hassan Bahrani now in another place other than Iraq, and because of the lockdown, he cannot prepare some cases. So he will present adaptive macular edema treatment challenges in Iraq for 8 minutes. After that, we will move to a case discussion series in which each one of our panelists will present some cases, and we will try to solve it each together. Okay. So I wish you all the best. Dr. Hassan Bahrani, now mic and screen with you. You can start.
screen on right now?
Yes.
You can see it. Okay, everybody. Okay, so thank you so much for the kind introduction, and I hope everybody's safe at home. Sorry about the quality of the presentation because this is just downloaded to my phone. Anyways, let's go ahead and get started because so I gave this talk about a few years ago about the challenges that all ophthalmologists see in Iraq, and I'm pretty sure that all other Middle Eastern countries face the same challenge. Not to the extent. Hello? Yes, is it okay?
Yes, we can hear you. We can hear you.
Can you please people mute their so to illustrate the challenges and to show how to overcome these challenges. So just a quick background, macular edema is very common. Diabetics have lifetime risk to develop macular edema is about 10%. So if you have if you have 2 million people, you're talking about 200,000 people having diabetic macular edema. And I'm sure these numbers are much higher. So we all encounter diabetic macular, whether you're a retina specialist or a general ophthalmologist. When we look at the medical challenges, there are different kind of challenges. But as far as the medical challenges is we don't have a screening programs in government institutions. And also we have late presentation to primary care physicians, late presentation to ophthalmologists, and therefore to retina specialists. And additionally, we have a lack of retina specialists, especially in the Middle East, compared to the number of population that we have. Again, poor diabetes control at presentation and poor hypertension control and poor follow-up. These are challenges we all face with our patients. Again, inability to patient to follow the complexity of the regimens because we are now, we're doing anywhere from 7 to 9 injections a year in order to control those patients. We hear about the treat and extend guidelines. We hear about the PRN guidelines. But to be honest, most patients really cannot adhere to all these things we throw at meetings. Most of my patient, I would say about only 20% of my patient actually can adhere to these strict guidelines that is put on in these general meetings, such as the American Academy, especially that most patients have to pay out of the pocket. Lack of other options, such as Lucentis, Avastin. In Kurdistan region, Erbil, where I work, we are not allowed to be using Avastin, so it's a big problem for us. Medical challenges in correct diagnosis, such as ability, training, hazy media, people not referring those cases to a retina specialist, lack of basic equipment such as macula lens, macula centralis, or not having the equipment such as an OCT to diagnose macular edema. One of the most common mistakes is to actually misdiagnose and continue injections with anti-VEGF, even though there is a very taut epiretinal membrane that most people don't diagnose, unfortunately. In this graph, you can clearly see the epiretinal membrane right over the OCT. And if you just spend 10 injections, it's probably not going to be helpful. This patient may need actually intervention, epiretinal membrane peeling. So other challenges, the cost of injection, most patients pay out of pocket. Comparing the price of FDA-approved medication with non-FDA-approved one, a patient do not realize that DME treatment is a chronic treatment for at least 3 years. I specifically talk to my patients and counsel them that they will need chronic treatment for at least 3 years. Again, transfer OCT. So I sometimes free OCTs for patients who are doing multiple injections to kind of lessen the cost burden on the patient. Also, availability of injections where we live in Iraq is really sometimes tough to get the original injections and sometimes even to get the actual injections. It's really tough, and I'm sure all other my colleagues, we are in a war zone torn country, restriction, checkpoints, security issues. All of these do affect lockdowns, such as coronavirus can affect that. We have, unfortunately, I would say, a badly organized healthcare system. We don't have a system, lack of healthcare insurance, scarcity of charities to help poor indigent patients, and lack of telemedicine programs. Additionally, cultural challenges include uneducated patients, sense of lack of government program to educate the public. Also, stigma of an injection in the eye. Most people are scared to have an injection. They're on the, fearing they're going to be blind. Misinformation from family and friends about prior unsuccessful injections or experiences, such as, for example, patient having an injection for neovascular glaucoma and having complications from neovascular glaucoma, going blind. He's going to tell his friends who has diabetic macular edema, oh, I got an injection and then I went blind. So, culture of rumors, uneducated media. We have some media intervene in this and talk about the danger of injections. Additional challenges, patients ignoring the fact that DME treatment needs a chronic follow-up with multiple injections, and people related financial burdens of OCT machines, lack of technical support from OCT companies, and poor technician skills when performing OCT. It's very important that your technician does the correct OCT testing and misinterpretation of OCT testing. So we talked about the challenges. Let's talk a little bit about the solutions. Government programs, early screening, doctor education, like what we're doing right now, and also for general ophthalmologists to establish a close network with internal medicine and endocrinologists, so they get those patients early on, they treat them very early. Also is very, very, very important to stress the importance of follow-up to your patient and lack of ability. Even though I have very little time, I do spend lots of time telling them, you need to come back. You need to go to my secretary and make an appointment. And we actually call them if they don't come back or lose their appointment. And also, you need to ask your colleague for help if you have a difficulty with that. There's nothing wrong with asking for help. Also, learn the current accepted DME injection protocol, treat and extend, and PRN. Remove hazy media such as cataract, vitreous hemorrhage, PCO. Spend some money on some tools like a 78 diopter lens. Most people use this 90 diopter lens, but there's not, you can buy a macular centralis and put some visco and spend more time examining the macula to find out if this is a focal DME or this is a diffuse DME. Obtain a fluorescein angiography instead of just using OCT. Fluorescein OCT is never I would say, an alternative to fluorescein angiography. Hello, everybody hear me?
Yes, we hear you, doctor.
Okay, and also the financial challenges. We need to educate the patient. I even tell the patient, you need to kind of save for these injections for the next year. You need to keep some money away for these injections. I do talk to them, and I do spend some time telling the patient that this is a chronic disease, and you need to be spending some more time with me. A lot of patients do think that they're going to have three injections, then that's it. And that's really not the case. Purchase an OCT machine, obtain a bank loan, or get some help. Other logistical issues with companies such as Novartis, leaving Iraq. There's no control over that, unfortunately. But collectively, we have to push legislation to make a better nationwide healthcare system for all Iraqis. So, and finally, education is very important. Take some time from each visit to counsel patient about the importance of home internal medicine follow-ups, general ophthalmology follow-up, blood pressure control. I have seen a lot of patients who are well controlled diabetically. However, their blood pressure has not been controlled. So that's why I do check their blood pressure in my clinic, and that is very important screening tool for you to do. Counsel them about exercise and follow up, and all address all stigmas and misconception of treatment, beginning with the treatment plan, the injection itself, that it's not painful, you don't have to be scared about it, and the importance of follow-up. Anyways, I think I exceeded my time. Thank you very much for having me, and I thank for all his help in creating this great meeting. I think that's it for me. Thank you.
Thank you very much, Dr. Hassan, for this nice presentations. And we all we know your situations, and everything is good. Now we will start discussion cases. Okay, I will ask Dr. Farid. Dr. Farid, please start to present your cases.
Hi, is screen on?
Yes, we can.
First, I would like to thank the organizer of the conference, especially Dr. Mohammed Tawfiq. Actually, I have two cases. The first one, it's not unusual. It is one of the common diabetic edema patients, but here I want to share the
screen. We cannot see it. Farid.
Right? Was it clear?
Yes, your voice is clear, but we cannot see your screen. Share screen, please.
Just one minute. Yeah, a minute. Share screen. It's our video, is it?
Now I can see your screen now.
You can do it? All right. It's all right?
Yes, it's okay.
All right. Okay. So just make the. All right. Yes. So in diabetic macular edema patients, always when I'm starting treatment with patients with diabetic macular edema, I have to ask myself two questions. The first one is the patient going to respond to the treatment I'm offering to the patient? If the answer is yes, then I'll go to the next questions. Is the visual acuity into a good level after treatment course? This is I have to put it in my mind before starting the treatment, and I explain to the patient very well. So I make just a small video. It's just not funny, but it's like to put an idea for everyone who's starting the treatment. He has to collect every piece of information about the patient, about the retina before initiating the treatment. So I hope the video is clear for you. I just got this video from one famous movie, it's Terminator. I don't know, is the movie clear, Mohammed?
It's clear, but it's a little bit frame by frame. We can see a little bit frame by frame. So you can comment on video so we can get the idea.
Okay, in terms of the video, there's collections of pieces of mercury, piece by piece, until making a complete man. So it's the same idea in treating the diabetic macular edema. You have to collect the information from the patient, from yourself, from the OCT, and until you build a complete plan, then you can stand strongly to figure out the accurate treatment and accurate diagnosis and treatment. So, all right, the next slide, this is before starting the case. Also, I would like to ask you a question, if the screen is clear for you. This is a diabetic patient. I got this video from YouTube. What do you think about the fluid collections in the central part of the macula?
So we can ask to Amin, what you can see?
I can see intraretinal cystic formation in the inner retinal tissues at the center of the macula.
All right, so if you're a diabetic patient, what do you think?
One of your friends are up pretty early.
I will say it's a central diabetic macular edema. I have to check the macular adhesion. I'm a little bit concerned if this will cause, it's due to vitreomacular traction. So I don't know, I need to see another slides or another.
Excellent. Thank you very much for this point. you have not to rely on one shot or one image of the OCT. It is a movie, I will move it. See here, it's when you scroll down all the slices of a 6 radial scan, you will see it is not an edema, it is a microhole. But if you depend only on the first one, you treat as a microedema. So it's very important to have a proper reading of the OCT before starting the putting your management plan. All right, I think I have problem. It's quite slow. Am I with you?
Yes, we can hear you.
We can hear you, doctor.
Probably just 1 minute. I'll start the program again. Is there a problem with the PowerPoint?
Shall we start? Or we
I would like to comment something until the program starts. About the OCT scans. There is a very huge mistake that people rely only on a topography map. When they send me a consultation to see an OCT scan, they send me only the topography map and only one cross section or vertical and horizontal cross section. This is extremely misleading. Just I wanted to comment about that.
Correct. This is the usual what's happened everywhere in the world when they send you a page of the OCT to ask for your opinion. Yeah, correct. So the first case actually is a 55-year-old adopted patient, the man, had a complicated phaco in the left eye for posterior cataracts done by a general ophthalmologist elsewhere. A few weeks later, after the phaco, he got a retinal detachment, and then he had retracted with the silicone oil. Then a few months later, oil has been removed, also somewhere else. And this was in October 2019. He came to me on March 3 this year, about 1 month ago. His best visual acuity, 5 meters. Pressure almost okay. The eye replaced with the open detractomized eye with the peripheral laser scars and flat retina with the mild non-proliferative dioptric. I will show you the RCT, and I will also, I want your opinion. What's the next to do for the patient? This is the, before I'm going to the RCT image, this is the signal is good, see it's 9, so it's good quality. And this is the 6 radial scans. All these scans almost the same, no big difference. So I can rely on this image. And this is the map of the macula in the center 524. On this scan, there is a big multicystic fluid collections in the macula, and there's disruptions in the inner and outer segments, and the external limiting membrane is not just defragmented as well. From this scan, what do you think the patient will respond to treatment, and what kind of treatment you prefer?
So I would like to ask Dr. Mohammed Tawfiq, what do you think about that?
For me, there is a large cyst. When you see this large cyst, I can, and with disruption of photoreceptor, I can guess that the patient have a poor visual prognosis, because this is a clue of a poor visual prognosis if you treat this macular edema. My choice of treatment in vitrectomatized eyes like this, pseudophakic, I will go for Ozurdex injection.
All right.
So, okay, I think we need to do fluorescein angiography. It is the history of sublime vitrectomy, and this would be a membrane or something else.
Right.
And yeah, unfortunately, we don't have it here in Basra because
but in if you have a fluorescein,
that's quite far.
if you have a fluorescein angiography, you can also rely on the ischemic area. If you find it in the ischemic area on the periphery, you can do it laser for that. But I think in vitrectomatized eye, unfortunately, the ischemic area will a little bit, I cannot see the
Just want to refresh your memory about the case.
Yes,
If the case is already vitrectomized and has lasers done on the periphery while doing the vitrectomy.
So, I mean, even in this vitrectomized eye, even you have to worry about injecting Ozurdex, to be honest. And also, I mean, it's kind of difficult when you have a vitrectomized eye because one, for Ozurdex injection, you may be injuring the retina. I know we do it, but there's a possibility that you may injure the retina because there's less tamponade for the vitreous to slow down the Ozurdex implant. That's number one. Number two, when you go to anti-VEGF injections, the VEGF molecule is going to stay, the anti-VEGF molecule is going to stay less and it's going to be cleared faster from the vitreous cavity. So it's kind of difficult, but I would, in this case, I would go for repeated anti-VEGF injections. And then if I don't see a great response, then I would consider Ozurdex injection.
All right. So here, it's what you think, the question for the panel is for the main cause is from diabetes or from surgery or both?
I cannot rely on this only OCT. Is it from diabetes or from surgery?
So I would need a FA, fluorescein angiography. As I mentioned in my lecture, fluorescein angiography is definitely an important tool, and it's not, the OCT does not, is not an alternative to fluorescein angiography. Even OCT angiography is not an alternative to fluorescein angiography.
I agree with you, Dr. Hassan.
All right. So actually, what I've done with the patient, because you don't have also Ozurdex here, I give an injections, Avastin plus Septinon triamcinolone, and probably in a week time, the curfew is up, and I can see the patient and repeat the OCT again. And if there is a facility to do a fluorescein, I cannot guarantee we can get it here. But probably I can do OCT angio. Yeah. All right. So this is the case. And the second one is quite young child. It's 14 years old, diabetic patient. And also left eye phaco-vitrectomy with silicone oil, then silicone removed almost 1 year ago. Is not very well controlled in diabetes. I presented this month on 16. Best corrected visual acuity 660, pressure is fine. Significant vitrectomized eye, stable PGR with the PRP, and there is maculopathy. The OCT, but before showing the OCT, the other eye, the right eye, and flesh eye, the cataract, mild cataract, the multifocal vitreal contraction, vitreous hemorrhage, and partial PRP. And OCT show on the other eye, partial macular detachment. So let us go back to the left eye. So this is the left eye. So the vision 660, what do you think? Is there any hope for treatment in this case? The same question. You will see, you need fluorescein angiogram, you're right. But if we are relying on the OCT, any idea?
I will definitely look at the infras OCT at this stage. I want to see the ILM to vitreous interface status. I want to see if there is still residual epiretinal membranes. This infras OCT will help me and guide me a lot here. And besides, we can see that the cysts are located at the inner or approximate to the inner retinal tissues. So it might be fractional by somehow. If you can provide us with the grayscale OCT, not the pseudo color, it will help a lot to differentiate between the tissues.
All right. Actually, I didn't.
Looks like there's epiretinal membrane.
But yeah, there's
Yes,
a
there is, but I want to make sure. I want to make sure about it by the in-pass OCT. But it is obvious in certain places, but it is not obvious if it's causing tangential fracture. That's why I need the in-pass OCT.
So, Dr. So, Dr. Farid, we can go back for your video that we cannot rely on a single scan, so we can detect any membrane. Because I agree with Dr. Amin that there is definitely a vitreomacular interface abnormality in this case, I think.
Yeah, I checked this all scans, 6 scans.
Yes.
There's no hole, but there is fragments of the remnant of the membranes over the macula. And this part, in the center part of the macula, there is scarring here. This makes me very hesitant to give him an injections or stop treatment at this level. And the very well demarcated cyst, and this is indicated chronicity.
For me, it's no rule of
my
injection.
opinion, I don't think this will respond to injection.
Yes. For me, it's no rule of injection in this case.
Yeah. All right.
Sorry, Dr. Farid, it may be macular edema associated with the retinal membrane, both conditions. So I think if you're seeing angiography and OCT8 or OCT8, if it's available for fluorescein angiography, this will be of great help for you.
That's correct. Yes. Correct. Thank you very much. It's done from my side. Thank you for sharing with me these 2 cases. And thank you for being
Great. Thank you so much.
Thank you.
Those were great cases.
I appreciate it. Thank you.
Thank you very much
Thank you, Dr. Farid.
for raising this
Appreciate it.
of management or how to inject or how to counsel our patients, because in retina specialty we have to counsel more than do surgical or other intervention. So now I will move to our speakers.
Sorry, Mohammed, just one comment. We don't need to treatment OCT. You must treat the patient at all. The photo is important. Fluorescein angiography, OCT angiography, all this is important. The decision of a treatment of patient.
Totally agree.
Totally agree.
Yep,
It's the
I
same
agree.
principle in medicine for ECG. Yeah.
Dr. Amin, please can you share now with us?
Yes, okay.
Yeah, I just want to say something while he's doing, he's getting the slide. Really, there's no substitute for fluorescein angiography at this point. Even the OCT angiography is not a substitute for fluorescein angiography. I have seen so many missed things just by using OCT angiography and without relying on fluorescein angiography.
Okay, can you see my screen?
Yes, Dr. Amin, we see.
Okay, let's start with case number 1. A 62 years old female pseudophakic, physical visual acuity is 200, known to be diabetic. Her HbA1c is 7.4. Fundus examination shows central diabetic macular edema with high risk proliferative diabetic retinopathy and pre-retinal hemorrhages. This is the fundus image. You can see the vitreous hemorrhage and the pre-retinal hemorrhage and diabetic macular edema. The OCT scan shows the pre-retinal hemorrhage and the cystic formations at the center with adhesion of the vitreous not causing significant traction. So what is your management at this point? Would you do PRP, retinal photocoagulation, multiple anti-VEGF with or without steroids, cross-planar vitrectomy? Would you combine both PRP and anti-VEGF, or will you do PRP then you head for vitrectomy?
Please, do we have a poll on your screen? If you can see it, if you can see, just reply on the first questions. If you can see.
There's no vote, Mohammed.
You can press on poll. You can see the bar down. There is a pool.
No, I will share it. I will relaunch the pool now. Now you can see something on screen.
Yes.
Okay. So maybe there is a technical issue. Dr. Amin, you start by asking the panelists.
Okay. Dr. Tawfiq, what do you think?
For me, in this case, I will starting with systemic control of diabetes and hypertension and prepare the patient for PPV.
Okay. And what the other panelists will think?
I will go and just to clear up the serious hemorrhage. If it's clear within 3 to 4 months, I do PRP. It's not, I prepare it for PPV.
Okay. So the most I agree with doing prosplantar vitrectomy for this case as an early vitrectomy. I would partially agree at the prosplantar vitrectomy with the micro micro trocars and the advancement has improved the visual acuity very nice. But I have approached this patient differently due to her bad financial issues. So I treated her with monthly consecutive injections of intravitreal anti-VEGF, aflibercept, and aflibercept here, not Eylea. I used Zaltrap, it's way cheaper. And I did a PRP 2 sessions, applying 2,000 burns. After that, patient missed appointments for 4 months and then came back with central diabetic macular edema, treated her with 2 consecutive injections of combinations of suprachoroidal triamcinolone and intravitreal aflibercept, Zaltrap every 8 weeks. Now, after all the mentioned above treatment, the patient resolved hemorrhages and central diabetic macular edema and improved vision to 20/40. So the take-home message here that sometimes the injections and patients and as Dr. Tawfiq mentioned, the glycemic control will play a very good role in managing those patients. So I go to the case number 2, a 53 years old female, pseudophakic, previous history of prosplantar vitrectomy. 1 year ago, her historic visual acuity is 20/63, known to be diabetic. Her glycemic control is 8.1%. Fundus exam shows central diabetic macular edema with marks of PRP laser in the retinal periphery. This is her OCT scan. It shows intraretinal cystic formation with increased thickness of the macula. I will point here. Can you see my cursor?
Yes.
Here, the stick and the increased retinal thickness, and you can see a little bit of remnant of ILM or from the brain, maybe who did the treatment didn't feel the ILM. So, what is your approach to manage this case? Is it intravitreal dexamethasone implant or triamcinolone espinate, intravitreal anti-VEGF, focal or grid laser, suprachoroidal triamcinolone espinate, or revision or of prosplantar vitrectomy?
The audience give you 100% for anti-VEGF.
100% for anti-VEGF.
Can I comment, Dr. Amin?
Excuse me?
Can I comment?
Yes, please.
Is it a diabetic vitrectomy?
Yes, diabetic vitrectomy. Sorry, I didn't mention that. Yes.
So the patient have a full
attachment to trace hemorrhage.
The patient have a full PRP.
Yes, full PRP. Yes.
Full PRP. So if I can do the patient FFA to be sure there is no area of ischemia and the patient is completely PRP, I will go for intravitreal anti-VEGF.
Okay. Any other opinions before I show what I did?
As a primary treatment, and if there's no response, we can switch to intravitreal corticosteroids.
Exactly.
Yes, I agree with Dr. Tawfiq too.
Okay. This is the patient. 1 week later, I injected her suprachoroidal triamcinolone. Patient improved vision to 20/40 within 1 week. The edema completely vanished. I can. The main idea of triams, in the suprachoroidal space, the suprachoroidal space will act as a reservoir for the triams itself. So as it's vitrectomized eye, the reservoir for the vitreous as a reservoir is already not there, and we have only vitreous cavity. So the wash out of the medicine will be faster. That's why anti-VEGF, I can agree with you, it will work, but the half-time of the acting material won't last for longer time. Here, it will last for 8 weeks. The patient won't need any other injections for the next 8 weeks.
I love your technique of suprachoroidal corticosteroid, Amin. You have a beautiful technique.
Thank you.
Dr. Amin is famous with this technique.
Yes.
I just want to comment to the audience. It is rarely do by us. This is suprachoroidal injection, but Dr. Amin is very famous by this technique.
By the way, doing
nice.
it by a cheaper method.
Excuse me.
Suprachoroidal injection, please.
Dr. Amin,
Excuse me, I didn't hear the question. Can you repeat it, please?
Do you have a video to show us how the procedure for suprachoroidal injection?
On this iPad, I don't have, but I can present in the next week how to do it. It's very easy. I take a 30 gauge needle. I put a 23 gauge sleeve stopper. I can obtain it from 5cc needle. I cut it at both sides and I rasp it, and I let only 1,000 microns, or aka 1 milli, from the 30 gauge needle, and I inject perpendicularly at the pars plana 4 millimeter from the limbus. And withdraw the needle after the injection obliquely from the eye to prevent regurg of triamcinolone outside the suprachoroidal space. I can present it in the future presentation, but unfortunately I don't have it here. Or let me see if I have a presentation. I will check. But let me just finish here the case. I will check. Okay. I think I remember I have one lecture. I have the video how I'm checking it.
Dr. Amin, please, cases will be presented by
Okay.
So this is the last.
Okay, a 37 years old female phakic, physical visual at least 2032. Fundus exam shows a small defect in the tight junction barrier of the RPE, pigment epithelial detachment, and subretinal fluid. As we can see, the fundus image is typically for CSCR. The early phase is showing early hyperfluorescence from pigment epithelial detachment. From then we have ascending hyperfluorescence leakage, and then we have the smokestack appeared with subretinal and sub-RPE dipooling. Here is the subretinal dipooling, and here is sub-RPE dipooling. This is CSCR. This is her OCT scan. We can see how the choroid is thickened, the hallers are dilated. Let me show for those who don't know it, what are the hallers for those. And we have thickening of the photoreceptor layer, the ellipsoid zone, not thickening, and elongation. And we have, of course, the subretinal fluids. So what is your approach to manage this case? Is it observation? Is it anti-VEGF? Is it subthreshold microsecond laser, or half-dose PDT, or eprilionone, or spironolactone? Just say one thing: she's an optician.
I think observation is a good choice for this patient. Just observation for the 3 months. If there is no response, we can go for half dose BDT.
Okay, totally agree.
I agree also on observation, and then if it doesn't work, maybe I would start with aldactone treatment, and then if it doesn't work, then you may consider quarter fluence, not half dose, quarter fluence PDT, which has shown to be great also in CSR cases.
Any other opinion?
Dr. Farid? It's the same Dr. Hassan opinion almost. It's no difference. Observation, second aldactone, and lastly DPD.
For me, I'm going for observation for 1 month. After that, I will start aldactone. And of course, before that, we have to exclude any causes like steroids abuse, any form of steroid, whether inhaler, topical, drops, systemic, any form, and to exclude any other precipitating factor. Then I will start with spironolactone.
Mohammed, one point. Do you have a photo to the optic disc?
You think about the bit?
Optic disc bit? No,
Yeah.
there's not.
No, it's
No,
not.
right.
It's not.
Just one thing. It has been recently advised that eplerenone should not be used in CSR. So anybody using eplerenone should not be using it, and maybe probably switch to aldactone.
Yes.
Eplerenone is, the anti-cortisol treatment, because there's a big study that showed it's ineffective. I used to use it a lot, actually, and I found that with the recent literature, I stopped using it at all.
Okay, Dr. Amin, hurry up.
Okay. As she is an optician, she had a very high demand for vision. So I treated her with a subtertial microsecond laser. Patient improved vision to 20/25 within 2 months. But I totally agree that we should observe the patient, because most of them are they might continuously regress and they do not need any treatment. I think I'm finished. I'm done by now.
Thank you very much. Thank you very much, Dr. Amin. Dr. Mohammed,
welcome.
Mohammed Tawfiq, please present your case. Mohammed Tawfiq, you hear me?
Other, I will present now.
Yes, okay.
كل الشاشات دي مفتوحة. I'm ready.
Yes.
So my case is 27 years old female patient presenting with right defective vision 2 years ago, with left recent defective of vision, have a night blindness, no negative past history, free systemic history. On examination, right IOP was 19, left IOP was 20, right pist-corrected visual acuity was 25 centimeter, and left eye was 0.2. Here is the refraction of the patient. The visual acuity was a pist-corrected visual acuity. On examination, I found the peripheral mottling in the retina with maculopathy. The macula was elevated, and there is, as you see, is a peripheral mottling in the retina. There is the image of infrared image. The pictures in the right eye presented like this because the retina is highly elevated, the macula is highly elevated. And you see in the left eye, there is an area of cystoid spaces, and this is the area of mottling. This is the autofluorescence. This is a pigmentation here and the mottling in the periphery of the retina, cystoid spaces, large elevation of the macula here in the right eye. And this was the OCT of the right eye, large splitting of the inner retinal layer, schitic retina. And in the left eye, there is a schisis in the retinal layer and splitting of the inner retinal layer. Can I ask Dr. Amin, what the next step you can do for this patient? And if you need another investigation, you can order what investigation?
I would ask, I missed, is she myopic?
No.
She's not myopic, because I can see how
this is not a myopic patient. You see the refraction now, huh? It's not a myopic patient.
I missed the refraction, sir. Or maybe this refraction is due to the elevation of the macula. It gave a false.
You agree with me? You agree with me? This is not an edema, or this is ascites?
No, this is a schisis.
This is a
I
schisis.
100% is a schisis. It's not an edema.
Okay.
But I'm trying to know what the cause of the schisis. If she's myopic, I would go for the. Or let's forget about myopia. Let's go about if there epiretinal membrane or any perivascular traction.
This is the color picture of the patient. There is no epiretinal membrane. There is no any tractional element over the inner layers of the retina. And this is the autofluorescence of the patient. That, as you see in the left eye, this is completely free. There is no epiretinal membrane or fibrous tissue traction directed on the retina. But in this level, for me, I order FFA, and this was the FFA. Dr. Hassan, can you comment on what we can see in the FFA?
Yeah, there's just blunting of the fluorescein vessels in the macula in the right eye. There's no evidence of leakage. There's a staining of this punctate, multiple perimacular punctate.
And there is the area of blocked fluorescence here over the pigmented area and the color photo, and there is also the cystic species here.
Yeah, I cannot. Maybe I should. I'm actually enlarging the photo. It looks like cystoid.
Yes.
Cystoid.
Yes.
Yes.
So now we have a case of bilateral macular schisis and peripheral mottling in the retina with no evidence of leakage. So what is important if fluorescein angiography here, that is no evidence of leakage. I am right?
Pooling. It's like almost like pooling.
Almost pooling. Perfect.
Pooling. Yeah, there's no leak.
Yes, the patient came with this VEB, recording that there is a normal NP amplitude, decrease in amplitude of both eye, denoting delayed retinocortical transmission. So I starting to thinking with middle-aged female, bilateral impaired vision, bilateral posterior poor retinoschisis, peripheral pigmentary changes with night blindness. Again, I start to ask the patient if there is a family history or not, and by luck, her sister is present in the clinic, and we starting examine his sister, who was 35 years old, 0.2, 0.4, doing the color photo, we see the similar peripheral mottling and pigmentation of the retina with no evidence of macular schisis in her sister, in her macula. So my differential diagnosis was, is it a stellate non-hereditary idiopathic macular retinoschisis, or X-linked retinoschisis, or degenerative retinoschisis, or autosomal dominant retinoschisis, neovascular AMD, enhanced S-cone dystrophy, secondary. For secondary, I will exclude all these 4 items: myopic degeneration, like Dr. Amin said, optic maculopathy, glaucoma, myotonic dystrophy. So we started to differentiate the other items: stellate non-hereditary idiopathic foveomacular retinoschisis, presenting in females, which was radial spokes at the fovea, negative family history, mostly unilateral, with preserved vision. If you think with X-linked retinoschisis, bilateral, presenting in males, childhood, with positive family history. If you think with a degenerative retinoschisis, there is a peripheral dome-shaped retinoschisis in asymptomatic patient. Autosomal retinoschisis, I think there is no in this. If we think enhanced S-cone dystrophy, it's a bilateral, impaired visual acuity, cystoid maculopathy, posterior poor retinoschisis, peripheral pigmentary changes, night blindness. Our case show all these items, but there is an abnormal ERG mainly due to cone affection. So I ordered the patient to do, again, the VEB and ERG, and was impaired. I started searching in the rule of carbonic anhydrase inhibitor in retinoschisis. I found the treatment of adult onset acute macular retinoschisis and enhanced S-cone syndrome with oral acetazolamide. There is a 3 paper. I was starting treatment, and after 1 month, there is no improvement of the schisis. Dr. Mustafa, you think we can treat this schisis and the patient complaining of vision?
Sorry, Dr. Mohammed.
We can treat this schitic macula or not?
I think observation for this patient is a good choice. As you know, retinoschisis may be complicated by retinal detachment and vitreous hemorrhage. I just observe the patient. I do no action for it. And if there is retinal detachment or vitreous hemorrhage, I will refer them for vitreoretinal surgery.
Dr. Tawfiq. Dr. Tawfiq.
I'm with you. I will go for observation only. There is no rule of treatment.
Dr. Amin.
I will go for acetozolamide. I have a very good experience with retinoschisis, but not that.
I already gave the patient acetozolamide for 1 month with no improvement. Actually, the schisis increased. Dr. Hassan, you have another option for treatment for this patient, or just follow-up?
It's a really tough case, but I would add maybe true soft drops, like a dorzolamide drops, maybe 3 times a day to both eyes. Really,
actually, we have after 1 month. After 1 month of treatment of carbonic anhydrase, I found that there is an increasing in schisis, and the patient reported marked again the diminution of vision in left eye. So I started to do the vitrectomy for this patient by active aspiration of this scatic cavity using a 41 gauge cannula. I hope the videos we can seeing it very clearly, but I think you're reaching the video frame by frame using this 41 gauge cannula. And this is what we can see after 1 month. Scatic cavity is decreased significantly, but the patient have not improved in the visual acuity, but improving in the central scotoma he found before the surgery. And after the finishing the surgery in her right eye, he did insist to do the surgery in her left eye. And also we do the surgery in left eye, and this was the result after aspiration of scatic cavity. After follow-up the patient 1 month and 2 months, all the scatic cavity is disappeared just by active aspiration of a scatic cavity using a 41 gauge cannula. My message is, make sure you analyze your case correctly before any decision. Restoration of the anatomy can sometimes surprise you with its effect on vision, even it takes long to prove that. Use all the available techniques you can help your patient with. Report your uncommon cases as it may help others as well. Thank you, Dr. Tawfiq, and thank you for your effort.
Thank you for the wonderful case.
Thank you, Dr. Hassan.
I just wanted to ask Dr. Tawfiq, why do you think the vitrectomy helped here?
Because we have articles and we have an experience in what we know active aspiration of scatic cavity. We use it also in optic nerve bed. This is the technique we use in optic nerve bed. So I think this large cystic spaces, if I aspirate this cystic cavity, I may improve the patient. What this was also we reached all the patient. I starting with the more diminution vision, the right eye, or more affected eye, and the patient reported that the central scotoma is improved, and he insisted to do. She insisted to do the left eye, and this is the
so you think it's a kind of mechanical removal of
it's a mechanical removal.
Fluid.
It's a mechanical, and by the way, it's not a fluid.
What is it?
It's not a leaking. Sorry, by the way, not a leaking process.
Is it degeneration?
It's not a leaking process. There is
Viscous, you mean?
Viscous, yes. If you can see the video, you found that I try to aspirate this fluid difficultly, not go through easily, because of the fluid inside the retina was very thick. Viscous fluid.
That's why acetozolamide didn't work, because it's not the RP couldn't pump it.
Yes.
So you put it on an extrusion needle and just active.
No, active aspiration of the VFC. Yeah. Active aspiration. In extrusion, we cannot do the job. It's very difficult. We need a powerful aspiration. Connect the.
You use the silicone oil extraction.
Yes. Connect the 41 gauge cannula to the silicone oil extraction.
Wow.
Yes.
So did you try first to do the extrusion cannula,
yes,
and it didn't work? And you moved to
exactly, Dr. Hassan. That I trying with the extrusion and didn't work, connecting again the 41 gauge cannula with the silicone oil extraction.
That's pretty scary.
That is working very nice. I can play the video for the right eye if it's working with you now.
Working very well.
No, this is not one. I will try this one.
What's the gauge of the cannula?
41 gauge cannula. You can see the fluid is very viscous when you can work. This is a small laser bit because the fluid, when you come out from this small retinotomy, he enlarged the size of retinotomy because the fluid was very viscous. You see the pictures.
Did you put any tampon on?
No,
Did you
just
put
air.
anything,
Just air.
Okay.
No tampon on?
No, just air.
Oh, okay, just air.
Thank you very much.
Thank you, Dr. Tawfiq.
Very nice presentation, very nice presentation, very nice work. I'm sorry for myself, my dear bro, Dr. Mustafa is waiting, cannot present cases.
Okay, I think we have the time to the next week.
Yes.
We complete our cases the next week for discussion, for this nice discussion with the brilliant retinal surgeons and the brilliant ophthalmologists. It's very nice discussion.
وحشنا والله يا دكتور مصطفى.
حبيبي.
Thank you very much.
Thank you, Dr. Tawfiq, for making our current very beneficial.
Thank you, Dr. Tawfiq.
Thank you, Dr. Hassan. Thank you.
Thank you.
Thank you. I will conclude my session, the session, retina session, and we will would like to welcome all of us with our international speaker from India, Dr. Ashwin Agrawal. Dr. Ashwin Agrawal, he will talk about mastering gluteal and pupilloplasty. All of us, we know Dr. Ashwin. He is a member of the ISRI, and he is so many in managing of complicated cases. Dr. Ashwin, you are with us?
Yes. Hi. How are you?
How are you doing, bro? How are you? I miss you so much. I wish you are safe with your family.
Yes. I hope everybody here who's watching is also safe with their family. So I really hope that everybody that I wanted to just, give my, we're all going through a really troubled time right now. Wanted to give my deepest regards to everybody who's fighting the battle out there. But important that we keep continuing the work of education. And in that light, thank you, Tawfiq, for having me on this panel. I saw some great work that's happening on the retina front. Though I'm not so much in touch with retina, but it always gives me pleasure to keep viewing such beautiful presentations. Thank you.
Thank you very much. Thank you very much. And you can share your screen right now.
All right, I'm going to share my screen. Here goes. So I thought, first up, before I even start my presentation, I thought, can everybody see the screen? Is it shared well enough? Tawfiq, if you can just tell me if that's shared.
Yeah, it's clear and shared. It's clear and shared.
Okay, perfect. So first up, before I start, any questions, you can just put it into the chat. I will answer. I have left 4 to 5 minutes at least at the end, or maybe more, for questions. I'm going to be talking about 2 major topics. One is doing scleral fixation using the glued intraocular lens technique. And I'll teach that with a lot more videos. And this is a purely video-based presentation, number one. The second thing that I'm going to talk about is pupilloplasty and the probably easiest way that you can do it and why we do it in certain many cases. So it's completely video, so please keep watching and enjoy. So the point here is gluteal. First, let's understand why we do gluteal. The reason why we do gluteal is when you have a capsule or a bag which is broken or which is not intact. Posterior capsular rupture, all these are some of the indications. And the last one I'll explain a little bit more, that's endothelial keratoplasty. I'll explain why it's so important to know gluteal in these cases, especially when you have a broken capsule. Okay, going to the surgical procedure, I'm going to dive in. I'm going to break it down slowly, one by one, okay? First up, what we have here, we have a conjunctival peritomy and cautery, which is done at 3 o'clock and 9 o'clock position. If you see here clearly, just cautery enough, not too much, just enough to cauterize that those bleeders. Second step, we use a gluteal marker. So this marker basically gives me the 180 degrees apart, 2 by 2 millimeters in size. This is the marker, and it's from the company called Epsilon. I have no financial interest in any of my topics today, but it's a brilliant marker. Really helps me every single time because I never go wrong if I just follow the tracks. That's the idea of this marker. Next, as I said, 2 by 2 millimeters. Let's see how I create my flaps. Exactly like how I do my trab flaps is how I do this. Even my trab, I make the same method. I use 3 partial thickness grooves and I go into them using a crescent knife. Once my flaps are created, I push in a trocar AC maintainer. I can put in a posterior one as well if you are more comfortable with that. But I've seen segment surgeons tend to than not because they're uncomfortable doing anything in the posterior segment and they don't know pars plana and they're not very comfortable with that. But yeah, so that's why we call AC maintainer. This basically gives me infusion, but I can get infusion from posterior or anterior AC maintainers. Next up is the sclerotomies. I want to make my sclerotomies 0.75 millimeters behind the limbus. And if you see here, this is exactly how I make them. Behind the iris, under the flap, and I go towards the center of the globe. Again, behind the flap, behind the iris, towards the center of the globe, not center of the pupil. Otherwise, you're going to be dragging iris tissue with you. Next up, I'm going to make my main and port incision. That's my side port, and this is my main port incision. I don't need a scleral tunnel for this particular surgery right now, but if need be, then I would do that as well. Next is my intraocular lens loading, and it's a very important step. I know a lot of us give it to our attendees or assistants to kind of do this, but it's a very important step. Why is it important in blue IOL? Let's just see this haptic. If this haptic turns out to be this way, it's fine if the bag is there. But if the bag is not there, it's going to snap and you don't have something to grab on. Always this sign called as the lucky 7 sign. Ensure that in the cartridge you have a lucky 7 sign. It was coined by somebody called Tom Otting from Canada. Now what we do is we inject the cartridge completely inside, push in a glued IOL forceps through the left sclerotomy, grab only the tip of the haptic. Make sure that you grab the tip of the haptic, not the flange, nothing else. The tip of the haptic, and then inject that intraocular lens. While injecting, externalize the leading haptic while keeping the trailing haptic outside. Once this is done, fold. What I'm doing here is ensuring my trailing haptic goes in. For ensuring the trailing haptic goes in, fold the trailing haptic, handshake it to the left hand, go through the right sclerotomy, hold again. Watch me, I'm going for the tip. Go for the tip and bring it out. Once this is done, you have both your haptic tips externalized. You can just leave the IOL, nothing happens, it does not go anywhere. So that's the handshake technique which I showed. Now we're doing the Gabor-Shariat's tunnel. The Gabor-Shariat's tunnel is made partial thickness at the base of the flap. This is how it looks, and this is how it's made in real time. At the base of the flap, circumferential to the limbus. Once you do this, you go all the way in. On the other side as well. Once you have both the sides tucked into the haptics are now tucked into the Gabor-Shariat's tunnel, and you have a stable lens. Even though all infusion is on, the lens is not moving anywhere. All I need to do now is to close this with some fibrin glue on both the sides. So I close both my flaps and my conjunctiva on both sides. And that's pretty much the end of the case in most of my gluteal cases. This is by far the easiest and fastest technique that I have for secondary IOL implantation. And it has many implications, but also it has some risks involved. And I wanted to share that with you guys. So here are some of the risks that you should be worried about. When you have a large cornea, when your horizontal diameter is more than 12 millimeters, always try to go vertical because the vertical diameter is lesser. These IOLs are not made for these sizes. The IOLs are made particularly only for in the bag placement. So if you do have a large cornea, please go for a vertical glued IOL. So make the peritomies at 6 and 9 o'clock and do the surgery from a temporal position. Next up, if you have too large a flap, see what you get with a normal sized flap is a good tuck. But if you don't, or if you have a large flap, you don't get a good tuck, and it has a chance to slip inside the eye again. So you want to be careful of making too large flaps. Next up, this is probably a big worry for most surgeons initially when they are starting this procedure. So you want to be worried about this. Just watch what happens. As soon as I go in, if I go too horizontal, I can cause an iris bleed, and that can prevent me. So what I tend to tell people is to go vertically down. Think vertically down. Think center of the globe. Think macula. You're not going to hit the macula. Don't worry about it. Just think in that manner when you're trying to make that angle. One other risk is post-operatively in a normal cataract patient, when you have a bag, you always have a capsular rim that protects any optic capture like this from happening. But in gluteal, you've lost the bag. So sometimes you may need to do a pupilloplasty, and I'll talk a little bit more about pupilloplasty later. But I'll leave that point, but just do a pupilloplasty even in gluteal cases. So this is one of the indications for any pupilloplasty. I use single pass photo, but we'll talk about that. You can watch all my stuff on my YouTube and Instagram channel. But important one of the implications where I use gluteal is sombering ring. Just look at this case. It's going to go a little fast, so just bear with me. I've made my flaps. I've made my trocar AC maintainer. I'm going in with my sclerotomy, done my anterior vitrectomy. Now injecting the lens behind this sombering ring, ensuring that the lens is behind the sombering ring. Now, quadrant by quadrant, I'm not going to come out with a vitrectomy. I've tried it. It takes at least 45 to 50 minutes for it to come out, and it all flies everywhere around. What I've done is basically created a scaffold, and I also sometimes have to use phaco to actually extract that nucleus, because it's like a nucleus. That sombering ring is like a nucleus. Again, you do end up with iris hooks sometimes damaging the iris, so you always want to be ensuring that you close that wound with some amount of pupilloplasty. This is the same patient 2 weeks post-op. And now, let me take you through a series of cases. I'm just going to share another screen with you guys. Any questions, please keep it going on the... Yeah. Okay, can you see that?
Yeah, we can see clearly, Dr. Ajman.
Okay, are you able to see what I'm showing? Is my video on or no?
It's now on. It's now on.
Okay, perfect. All right. So a lot of times I get one question that is being asked to me a lot more than normal is, what do I do if I don't really need a gluteal, but sometimes you really need to do something different. And this is where I'm doing a gluteal, but not exactly to gluteal. So I'm not actually, watch what happens in this case. So basically what's happening here is, this is a subluxated case. And I can see that subluxation site is on the side where I'm making my side port now. I've put a capsular hook. I hope everybody can see it clearly. Anyways, I've put a capsular hook in place so that it retains the bag and makes sure that the bag is stable during my surgery. Now, while I'm doing my surgery, please do a good hydrodissection. In these cases, always do a good hydrodissection. And ensure that once you'll be able to get these nucleus out, because they're rather soft and they're in these cases. So once you've gotten the nucleus out, even the cortex and the epinuclear bole comes out rather easily. You want to be a little careful on doing irrigation aspiration, especially in that side of the subluxation. What I'm trying to show here is not how you manage the bag or the cortex in this case. What I'm trying to show here is, what do we do after that? Now, after this, if you do place a 3-piece IOL or a single-piece IOL, you probably could manage for a year or so. But after 5 years, believe me, I've seen many of these progressive conditions come down with an IOL bag complex on the retina. And we don't want that. So in this case, what I'm doing is making my flaps. Remember, I have not done any trocar, I have not put any infusion because my vitreous is not yet disturbed. Okay, my vitreous, if my vitreous gets disturbed, I'm going to switch to plan B, but I don't need to do plan B right now. Now, watch, my sclerotomy is in the sulcus space. My sclerotomy, again, watch again. My sclerotomy is in the sulcus space, not into the posterior segment, it's in the sulcus space. Now, I'm using a hybrid technique of where Yamane taught us very well of how to feed the haptic into the needle. I have no infusion going. I've not done vitrectomy. I don't need to because I have my capsular hook actually holding the bag in place. Now, once this happens, while I'm folding this lens haptic, ensuring that it goes inside. Now, once this is inside, again go back through that sulcus space, hand it by a handshake technique, and externalize the second haptic. Again, remember, the bag is still there. I have not removed the bag in this case. So this is glued IOL, but not glued IOL. It's a subluxated case. I wanted to ensure that I have, how does this help? I mean, some of the questions that are asked, is how does this really help? I could have just taken off the bag and done a full-on glued IOL. But the idea here is not to disturb the vitreous, to ensure faster recovery, to ensure that lesser chances of reaction post-operatively. You have a great, you really have not gone and disturbed the vitreous. That's one of my major takeaways from this whole thing. In 3 weeks post-op, this patient sees it brilliantly fine. Something that I wanted to showcase. Now let's go to single pass fourth row. Let's try and understand pupilloplasty as well. Pupilloplasty, job, it's a shutter's job. Now, if you take a look at any defect of iris tissue that you have, you always have a proximal iris and you always have a distal iris. Anywhere, any defect that you have. I'm going to show you this step by step. You make a stab incision at the distal end, so you call it the distal incision. The proximal incision, you really don't need one because the needle just passes through. So you have a proximal incision, a proximal iris, a distal incision, and a distal iris. Okay, this is the distal iris, and that's the distal incision. Railroad that 26 gauge needle through the distal incision iris, and using the 10-oproline or a 9-oproline suture, I've railroaded it. Now understand the suture trail. Break this down. Understanding the suture trail is, here I have part 1, which is external to proximal incision. Part 2, which is proximal incision to proximal iris to distal iris to distal incision, and distal incision to external. Now, question asked is, where do I take this loop? The loop, where do I take the loop? So the loop is always taken from part 2. Bring the loop out through the distal incision. Part 2, loop, bring it out through distal incision, cut part 5 and loop it 4 times. So it's 1 pass, 4 throws. It's very simple. It's a single pass and 4 throws. Now just pull part 1 and part 5 apart. Just pull them apart. All you have to do is pull them apart. So all it does is over here, it forms a helical knot, which basically helps tie down that iris knot tissue together and settles it down. This is something that we all need to understand and get into very quickly because it's such an easy technique. Believe me, a lot of people who tried it the first time just went ahead and have switched over to this technique immediately. What happens? Why do we do it? Because it reduces my stress, reduces the number of times I go inside the eye, reduces the number of manipulation of my iris tissue, and also improves my recovery phase. Where do I use this? So one of the questions asked is, some of the case scenarios where I can use this is in any endothelial transplant. So look at this case. This is, let me show you pre-op of this case. This is the case with a very bad pseudopechic bullous keratopathy. I am placing my trocar because this is a longer case than normal. The IOL is in place, but there is a big defect. Now, what happens with these big defects is if I push air, the main thing that I need in endothelial transplant is air inside the eye to hold the graft in place. If I push in air with a big defect of iris, the air is going to go all the way into the posterior segment, and I'm not going to have any tamponating effect from that air. So really want to close this pupil inside. So that's one of my reasons to do a pupilloplasty. And the pupilloplasty of my choice right now, see how many I can make within the same time span that I would have had to do just one. So this is some of the areas that I really use pupilloplasty to a better technique. As you saw here, I have made three pupilloplasty, which I would have usually done just one. And now I've gone ahead. I'm not going to show you the endothelial transplant, but eventually I'll just show you some of the post-operative pictures of this. This is the end of the case, and it really did really well. See the air, it actually stays and holds that bubble in place. That's the idea behind doing this pupilloplasty technique. I wanted to show you this very interesting case as well. It's probably going to be my last case because I really want to take some questions as well. So how do you combine these iris repair segments? I'm talking about a lot of trauma. This is a traumatic case. If you see here, there's pupil tear as well as an iris tear and a root tear. So I'm going to skim through the whole cataract portion because there was a need for glutathione as well. Because if you see here, there's a big, thick, fibrous band that's grown here. And the only way that was coming off was because if I had used a vitrectomy cutter and removed it. Plus, if you see the sheen of that bag, it's not really a really nice bag to keep a bag IOL in place. So I did perform a glutathione in this case. I did eventually. Now, let's break this down a little bit more. Let's understand iris tissue here. Now, what's happening? First, sit and analyze where is the defect, because this is completely confusing. I can't leave this patient just like this. He's going to have so much trauma. So first things up, I have a root tear, so I take care of the root first with a single pass 4-throw pupilloplasty. Here it is, the root. Again, watch me, I'm not taking care of the pupil over here. I'm taking care of the root first. The iris root is first taken care. Loop created, brought out, cut, and 4 throws given. 1, 2. There are 4 throws made there. And I pull apart. Now, is it over? Can I leave this patient just like this? I've taken care of the root, but is that enough? Let's reanalyze. Now, how bad is it? Because now is when you really realize there is close to 180 degrees of iridodialysis here. Watch this. This is a huge iridodialysis and cannot take care of itself. I will need to do an iridodialysis repair. So I'm combining a pupil repair with an iridodialysis repair. And what am I using? I'm using the flap where I made my glutathione. I'm using the flap where I made my glutathione to do a hangback technique. The hangback technique basically involves a double arm proline suture where I'm taking just both the sides of the suture, passing them through an incision and allowing it to come all the way back, tie them under the flap. If you don't have a flap, you can use a scleral ridge or a groove or a tunnel. I had a flap over here, so I used that to cover the knot. But I'm not done yet. Look at that edge of that optic. That edge of the optic is going to cause me a lot of trauma. Especially the patient's vision is not going to be clear. So now I have the leaflets. If I had done the leaflets in the beginning, then I would not have this advantage right now. So what I'm doing here right now is closing this final single pass flow through. So I've done 2 single pass flow throughs in the same case. So what I'm trying to show you here is combining iris repair procedures can get you absolutely stunning results. More so because the patient quality of vision, this is post-op day 1. Just imagine if I had just left the patient without all of this. Patient improved to 20/30 by the time he was 3 weeks out. I was so happy and excited about his vision, and something that we all really need to get into at some point in our this thing. I do have a lot more to show, but I think because of time, I want to take some questions as well. I'm happy to answer any questions there are. I'm sure there are. I hope everybody can hear me.
It was a very nice presentation, Dr. Ajman. It's as usual, your presentation in live and in online, it's same quality. Thank you very much for your presentations and for your knowledge. Now, if you have any question, please, you can raise your hand and our guest speaker, Dr. Ajman, will unmute you.
So somebody is asked over here, using a CTR, what if you apply a CTR? I think this is about the case where there was a slight amount of subluxation there. So I have used CTR, and I do use CTR in traumatic cases, and I think they have a very, very high reason in trauma, or wherever there is no progression to the disease, I will use a CTR. But if there is a progression, and that was a 35-year-old patient, I mean, he has 40, 50 years more to go. And there are so many times that I see, these patients come back 5 years, 10 years out with a CTR IOL bag complex completely on the retina, and I have to go pick that up. There are more questions, and that's one of the reasons why I started moving to glued IOL more than this.
Okay. Hello, sir.
Now, can you ask a question to Dr. Ajman? Dr. Ahmed.
Yes, okay. Hello, sir. Can you hear me?
Yes, I can hear you very clearly.
Okay, thank you very much for the marvelous presentation. I'd like to ask again about the technique of the pupilloplasty. You said that after the loop, we get it out of the eye, then we do a cut. I missed this part. We cut what exactly? I'm sorry.
The distal end. You see the distal end, wherever I pull the loop out, that end is cut because I have an extra suture there left. I have a lot more suture on that side. So I just cut off that, but I can loop that end into this. That end should go into the loop. I think what I'm going to do is I'm going to show, because I have a few minutes more, I might want to show you that because it's very important to understand this.
If you please.
Yeah, no problem. Can you see the screen?
Yes, I can.
Okay. So this is part 5. This is the part 5 which I want you to cut off because there's extra suture there. Now I'll show you this in real time, okay?
Okay.
Loop going through. So before this, okay. So now I take the loop out. I've taken the loop out and I cut that end. There's extra suture on that side, right? Yes. I'm not cutting the loop. Watch me. I'm not cutting part 2 here.
Okay.
I'm not cutting this. Can you see my cursor?
Yes, I can.
Okay. I'm not cutting this end. I'm cutting this part 5, this end of the suture.
Yes. Okay.
Okay. I hope that's clear because it's very important to understand this. And I know 2D images cannot explain this. I have tried so many times to explain on 2D. The only way that explains it is that's part 5. This animation shows it. I'll put it up on my Instagram page very soon and probably put it up on my YouTube channel as well. So it'll help people who want to see this and view this again and again and again because it's so simple. But once you understand it, it's very simple. And then just pull part 1 and part 5.
Dr. Walid Tantawi, Kuwait.
Yeah, can you hear me?
Yes.
Yeah, thank you very much for the presentation. In the same case of the simple subluxation, why didn't you put a 3-piece IOL in the sulcus?
Which one? The subluxation case?
Yeah, the 35 or 30 plus years old.
We have, I've done that so many times, and believe me, at least 25% of times they come back with a decentered IOL, where the optic will be somewhere in the mid-pupillary zone, and really a patient does complain. This is the most stable way that the IOL stays stable, stays centered, and no tilt. The amount of tilt that I get with subluxations is a lot more, number one. Second is that was a progressive condition. As I said, if it was not a progressive condition, I would have left it. I probably would have put a CTR and put it in the bag as well.
Yeah, but
if there's any, sorry.
in such young patients, they get very strong adhesions in short time as a reaction to the IUL. So even if the condition is progressive, that will happen in the bag. And
so they do tilt a lot more. So that's a big issue there. I think we underestimate the tilt issues which the patient foresees, because I do a lot more work on astigmatism, and that's a tilt issue that can be corrected on table on the first primary surgery itself. That's the only reason.
All right. Okay. Thank you.
Right.
Dr. Opthalko?
Yes, hello.
I
Good
think we have.
My question is very simple. Can you hear me?
The last question, Ajvan. This is the last question.
Just the size of a Gaber-Shariath scleral tunnel. What's the size of the needle that you went in when you created the tunnel for the haptics?
Perfect. 26 gauge.
26 gauge. It's enough for it to stabilize.
More than enough. In fact, the tighter, the snugger the fit, the better it is. So I use a 26 gauge. You can go even 24 and just open up that a little bit.
Do you angulate down a little bit? Do you go half depth, or you stay on the same plane?
Base of the flap. Wherever I have made my partial thickness flap.
After you go into the flap, do you base it a bit down? You angulate it mildly, or you just create it under just a straight stab?
Straight, not stab. It's not a stab. It's intrascleral groove. Yeah, it's an intrascleral groove. Yeah, exactly like that. I don't change much.
Thank you very much.
All right.
Thank you very much, Dr. Ajvan, for nice presentations.
Thank you.
And I would like to, for the audience, there is a special YouTube channel for Dr. Ajvan Agrawal. It's show a lot of educational video. You can visit it, and also you can add Dr. Ajvan on Instagram, Facebook. I'm sure he will be more than welcome to answer any questions. Word to you, Dr. Ajvan.
Yes, sir. I think somebody is asking. What about Yamani? Yamani is a great technique as well. Yeah, you can definitely use that as well. But I think the implication, Yamani is a much more popular technique for sure. But I think a lot of the difficult cases, blue dial is the way to go. And it's much more forgiving. That's all it is. It's much more forgiving. All right. Thank you very much.
Thank you very much, Dr. Ajvan, and we would like to invite you sooner in our next conference, if it's available.
Yes, absolutely.
Yeah,
yes, sir. Thank you very much. Thanks, sir. Thank you.
Stay safe and stay high for your family. Thank you very much.
Yes. Bye-bye. Bye-bye.
And actually, thank you very much for Dr. Ajvan for this nice presentations. And now we will move to our next sessions, in which we will invite Dr. Didar. He's a cornea specialist. He will talk about all you need to know about cross-linking. Dr. Didar, you are with us?
Yes, I'm here. Do you hear me?
Yes, I hear you very clearly.
Okay, very good. So, shall I start?
And you are welcome.
Okay, I'll okay. Let me just. Okay, so do you see the screen?
Yes, now it's okay. Okay, Dr. Didar, time to you.
Okay, so I'm going to start about what you need to know about cross-linking, and let me see if slides moving. Yes, so the aim for cross-linking actually to halt the progression of keratoconus, as we know. And the keratoconus, the problem with the keratoconus is the weakness in the cornea that leads to the bulge of the cornea and to irregular astigmatism and distortion of vision, affecting the patient's quality of life. Why the cornea becomes weak? As we know, the cornea has a backbone in the cornea. The backbone of the cornea, actually, the main backbone is the Bowman layer. The Bowman layer, as in the pathophysiology of the keratoconus, when it gets affected, when the Bowman layer gets weak, the cornea gets bulged, doesn't withstand the intraocular pressure, and becomes bulged and becomes keratoconus. The Bowman layer acts just like the iron beam. You have seen the iron beam in the construction of the building. It has two strong parts, the outer and inner part. The outer part here is the Bowman layer, is the most important part for the strength of the cornea. They don't mention anything about the role of Descemet's membrane and the strength of the cornea, but actually, personally, I believe Descemet's membrane is also weak in keratoconus. It's not only the Bowman layer, it's the whole cornea is weak, including Descemet's membrane. What actually supports my thought is when you have an infection like total melting in the cornea, like in pseudomonas keratitis, you still have an intact, sometimes an intact Descemet, leading to Descemet to seal. The powerful aggressive bacteria cannot invade Descemet. So Descemet is really strong. But in case of advanced keratoconus, when you have advanced keratoconus, when you have break Descemet, leads to hydrops. So it means that the whole part of the cornea, including the Descemet, gets weak. So the two important backbone of the cornea is the Bowman. Bowman is the main part, and then the Descemet membrane. It's just like the iron beam. So just like we mentioned, the main part that gets weak is the Bowman. When it gets breaks in the Bowman layers lead to keratoconus. And actually repeated breaks happens when there's advancing or progression of keratoconus. And that's what we see when we have advanced keratoconus, we have apical scarring. And the explanation for the apical scarring is the repeated breaks, and the repeated actually healing leads to scarring. So once the Bowman layer is weak, and we have keratoconus, when we try to manage keratoconus, when try to actually regain mechanical strength for the cornea, we have to have another Bowman layer. We have to introduce another Bowman layer in two brackets. So how do we do that? We can do it in two ways, actually. First way is the cornea cross-linking, and we can do cornea cross-linking when we make the anterior part of the stroma stronger by cross-linking. We can use that in mild to moderate keratoconus. There is a new way actually advocated by Dr. Millis from Netherlands is actually Bowman layer transplant. In advanced cases, when you have a thin cornea, when you cannot do a cornea cross-linking, then you can actually transplant the Bowman layer, and it acts just like cross-linking. It stabilizes the cornea, and makes it more fit for the keratoconus, for the contact lens fitting. So the cornea cross-linking, just like we mentioned, strengthens the anterior part of the stroma, just like it creates a new Bowman layer. It prevents keratoconus progression. Actually, there are reports suggest that cross-linking can improve topographic and refractive and abarometric parameters too. To me, cross-linking actually improves this mostly the aberration. I mean, topographic refractive is always gets stabilized, yes, but improvement, I see much improvement in aberration. That's why the patients, most of the patients, they are happier after cross-linking. They see better. They say, doctor, I see better. Their visual acuity is better, and they can see actually less shadow to the letters. So the aberration is much better. And countries that adopted cross-linking early, they have actually reduction about 50% in doing keratoplasty. So it's a really good technique to adopt early, to do cross-linking for the keratoconus early to prevent progression and prevent doing keratoplasties. So when to do cross-linking? Actually, I mean, the indication for the cross-linking is undocumented progression for mild to moderate keratoconus. However, there are nowadays almost consensus that clinicians should actually consider cross-linking in keratoconic individuals with high risk of progression, even if there is no documented progression. I mean, they will progress, but you didn't catch the documented progression. So it's better to hurry and do the cross-linking rather than wait for those high-risk patients. Who are those high-risk patients? Pediatric groups. I mean, the younger, the faster you should do cross-linking. Actually, the youngest keratoconic patients have been recorded is 4 years. I've done cross-linking for a 7-year-old patient. Those eye rubbers, the aggressive eye rubbers that cannot be controlled, or a family history of keratoconus in the first degree relatives especially, or if you have a minimum corneal thickness less than 450, for example, if you have a 420, you don't want to wait actually. Sometimes if you want for 6 months and comes back at the 6th month, and the corneal thickness now is 390, so you miss the opportunity to do cross-linking for this patient. So it's better to not wait and do cross-linking for this borderline patients. Another risk, for example, is for those patients who are not following. For example, in our locations, we have patients from the rural area, they are careless, they don't come back for following. So I think in this case, if you see some of those patients, especially if they are young and there are other risk factors, it's better to do cross-linking rather than following them. So how the corneal cross-linking works? It creates chemical bonds inside the cornea, inside the corneal stroma, between the collagen fibrils, and it's in the anterior stroma, specifically in the anterior stroma, just like adding another new bone layer. And we use riboflavin. Why we use riboflavin? Why we don't just apply UV light? Because we need a sensitizer. So the UV light sensitizes the riboflavin, which is a photosensitizer, because the wavelength for the riboflavin at the peak for the UV light is 370. So once the UV light hits the riboflavin, it photosensitizes, it fluoresces. One fluoresces, it excited into triple states and produces a reactive oxygen species. This reactive oxygen species actually activate an enzymatic pathway, chemical pathway. So this is a lysyl oxidase enzymatic pathway, which forms in turn the covalent bonds, and this is called photopolymerization. So you have a monomer with this chemical reaction becomes polymer. So that's why it's called polymerization, and it's induced by photosensitization. That's why it's called photopolymerization. Just like in the right-hand picture, if you see we have fibrils, collagen fibrils here, and before cross-linking, the below picture actually, there's a few covalent bonds between the collagen fibrils. Here, after cross-linking, we have more bonds. So from monomers becomes 3D polymers, just like in the right side picture in the upper corner. You see how it becomes a 3D picture because of this cross-linking in between the parallel filaments or parallel loops in here. We have also age-related cross-linking, which is the same thing. It's by means of the lysyl oxidase enzyme, but it's age-induced. When we do cross-linking, what happens? We cross-link, just like we mentioned, the anterior stroma. If you look at the OCT here, you see the demarcation line. I don't know if you see the my cursor. It's showing the demarcation line. The fibrils, the collagen fibrils is regular. Here is less dense, while here it's more dense. They're 200 micron. And this is the area where the cross-linking happens. There's more bonds, so it appears denser. So a lot of doctors, physicians concerned about haze in cross-linking. They are really concerned when they see haze after cross-linking. They ask questions why this happens, and they are concerned. And actually, there is no role for concern here, because haze should happen after cross-linking. If you don't have, it's a sign that cross-linking works. If you don't have the haze, there is no cross-linking. But the problem is there is scarring. So scarring is a complication, but haze is actually a must. If you don't see haze, you should question your cross-linking. And it decreases with time. It's visually non-significant. But the problem is when it becomes scarring. And actually, I noticed the scarring happens usually later after 1 year of cross-linking, especially the conventional way. We're going to mention this in later slides. So they started doing cross-linking in 2003 when in Germany, a group of researchers in Dresden, they came up with this protocol of doing how to do cross-linking. They published a paper in 2003. Their protocol is to remove the epithelium and then to instill the riboflavin in 2 minutes, 30 minutes. Then they apply the UV light in the energy of 3 milliwatts in 30 minutes. And they actually continued doing the riboflavin drops every 2 minutes during the UVA application. And please pay attention to this. They continue it, riboflavin drops every 2 minutes during the UVA application, because we're gonna talk about this in a second. So in dressing protocol, the key components of the cross-linking is the riboflavin and the UV light, and the UV light has a fluence actually. The fluence is total amount of radiation at the end, what amount that the cornea gets, and the treatment time. So let's go back with the continuation of the riboflavin drops every 2 minutes. And this was the Dresden protocol. Nowadays, actually, especially Dr. Farhad Hafiz, he advocates that during the UVA application, you should not instill riboflavin drops, because just like we mentioned about how the cross-linking works, the mechanism of cross-linking is UV light hits the riboflavin inside the cornea. It becomes excited, produces oxygen species, reactive oxygen species. This induces the chemical pathway, the enzymatic pathway, producing chemical or covalent bonds. So if you have a riboflavin caught on top of the cornea, then the UV light will cross-link, will actually photosensitize the riboflavin on top of the cornea instead of the riboflavin inside the cornea. So therefore, nowadays they think it's better to not put riboflavin during the UVA application, instead of just wet the cornea with the DSS. So as let the UV light hit the riboflavin inside the stroma rather than hitting the thick coat, actually, riboflavin, and still it on top of the cornea, doesn't go away right away. So it actually absorbs all the UV light, doesn't let the cross-linking to happen inside the cornea. Let's talk about riboflavin. What happens, what advances happen to the riboflavin component. The riboflavin, the mechanism of the riboflavin, just like you mentioned, acts as photosensitizing agent that propagates the chemical reaction that you mentioned. It also, another function for the riboflavin, it protects deeper tissue by reducing the UV light transmittance. So when you have a pachymetry for 400, this is the minimum pachymetry of 400 for the Dresden protocol. It should not be less than 400 micrometers, micron, after removing the epithelium, because when the cornea is saturated with the riboflavin, the UV energy will be dissipated when it reaches the endothelium. It will be about 0.18 microwatt of energy, and it is actually half less than the 0.35 milliwatt that causes the damage to the endothelium. So this amount causes damage to the endothelium, and by the Dresden protocol, when the pachymetry is 400, then only this amount, which is 0.18 milliwatt, will reach the endothelium, which is not lethal, or which is not causing any damage to the endothelium, and hence doesn't cause any damage to the crystalline lens and the retina. Riboflavin, as we know, usually has 20% dextran. What is the aim for the dextran? Why dextran is in the riboflavin? Actually, it coats the riboflavin for better penetration and also for better absorption of UV light. However, dextran causes cornea thinning. This is very important to know, that the cornea thinning after corneal cross-linking is not a sign of keratoconus progression. Many doctors that I've seen, physicians, that repeating cross-linking for a patient who otherwise visual acuity is very good, they're happy, their topography is good, fraction is good, it's stable, just they saw thinning after a few months of the cross-linking. They were concerned this is a progression, so they did repeat cross-linking just because of thinning. This thinning actually is okay. This is due to dextran, so it should not be concerned and should not do any repeat. There is no other signs of progression. However, newer dextran-free riboflavin are available nowadays that causes less corneal thinning. Another topic is related to the riboflavin is epi-on or epi-off cross-linking. Why the epi-on came up? Because the concerns about the epithelial removal causing post-operative pain and slow visual recovery and also infection risk. However, AP-on is causing mixed results, actually, conflicting results. They are concerned about the efficacy of the AP-on. And why is that? Because of the riboflavin penetration, because you don't remove the epithelium. So the riboflavin doesn't penetrate the epithelium, and then you don't have a riboflavin inside the stroma, so the reaction doesn't happen. So you don't have a cross-linking. And especially if you use the same riboflavin for the EP-off, because it contains dextran. Dextran is a large molecule and doesn't penetrate the epithelium. However, newer EP-on riboflavin contains no dextran, and also it contains other materials like benzalkonium and also NaCl and different proportions to promote the permeability. And some other physicians, they use LTA or tetracaine or different actually medications before the surgery to loosen the epithelium junction, and this makes the penetration of the riboflavin better. So still, even though the EP-on, there is concern about its efficacy, there's conflicting results actually. Results from Europe and Middle East, they found actually EP-on doesn't work that much. While results from the United States, they found better results. And I believe it's probably because of the technique of the cross-linking or the riboflavin they use. I know that the riboflavin, probably there is different component. They use probably benzalkonium inside it, or it doesn't have dextran, so or probably it's just bias. So AP-off is, AP-on is not only not effective because it doesn't allow the riboflavin to penetrate the epithelium. There is another function is when there is epithelium actually, there is less stromal oxygen replenishment because the epithelium doesn't allow the oxygen to be replaced when you do the cross-linking. So you need oxygen, and the epithelium doesn't let the oxygen to be replaced. So this is another factor that the EP-on doesn't work as good as the EP-off. And the important factor is epithelium contains antioxidants, just like ascorbate and tryptophan. This will remove the oxygen, scavenge the high energy reactive oxygen species. And we need those species to do the reaction for you. But when you have epithelium, you have ascorbate and you have tryptophan, and this will scavenge the high energy reactive oxygen species and reduces the reaction of the cross-linking in the stroma. Another matter related to the riboflavin, you know that we need to instill for 20 to 30 minutes every 2 minutes. This is time consuming for the surgeon, and also it's bothersome for the patient lying down for 30 minutes, instilling the riboflavin. They came up with the idea of ionophoresis. Ionophoresis is actually not a new idea. It's just was utilized before to deliver medicine to the skin, just like in the right top corner picture. They used a small amount of electric current to actually facilitate delivery of the medicine from the skin to the blood vessels. So the same idea, they use a small electric current to facilitate the delivery of the riboflavin to the cornea. The problem is here, instead of like 20 to 30 minutes instilling riboflavin, you do just 5 minutes. The problem is just you need a well that holds the riboflavin, and you need a suction to hold, just like in the picture on the right side, to hold this well on the eyeball of the patient, and the patient cannot move, otherwise the section breaks, and the section breaks, the riboflavin comes out, and you have to repeat again, and then all wiring and the gadget of the patient is probably causing discomfort for the patient. And still there is a problem with the research and papers finding that it's not as effective as the conventional way. So another thing is accelerated cross-linking. Another key component was the time. So they thought about how to reduce the time of applying the cross-linking to the patients. The Bunsen-Roscoe law of reciprocity mentioned that if you increase the energy, you probably need lesser time to have the same total fluence, which is about 5.4 joule. So if you look at the here, if you have 3 millimeter watt in the conventional way, you need 30 minutes to have the same fluence, which is 5.4. If you increase the energy to 6, then you need 15 minutes. So if you increase to 9, then 10 minutes. If you increase to 18, then 5 minutes. Then if you increase to blah, blah, until you reach probably seconds. But this is not true in reality, actually, because the more acceleration, there is a more problem with oxygen depletion. So the faster you go, there is more oxygen consumption and depletion, and there is no time for the replenishment for the oxygen. So therefore, the very accelerated cross-linking is not as effective as the conventional way. However, if you go midway, like 15 minutes to 10 minutes, it's still effective. Therefore, nowadays I do 10 minutes because it's still effective. There's still time for the replenishment for the oxygen. It works, and I prefer 10 minutes than 30 minutes. And also because another reason I prefer 10 minutes that I found with the 30 minutes conventional dressing protocol, most of the patients, they get scarring after 1 year of cross-linking in their cornea. So when we talked about that, the more acceleration you go, the less oxygen available for the cross-linking. So they came up with the idea of the pulse cross-linking. So they said, what if we do the application of the UV light in pulse? We do 1 second UV light and then pause for 1 second to allow replenishment for the cross-linking, for the oxygen replenishment. Then you do cross-linking for another second until you finish the, for example, 8 minutes or 5 minutes. This is theoretically a good idea. However, there's a concern that oxygen diffusion takes longer time than 1 second they allow in between to be replenished. Therefore, still the cross-linking is not as effective as the conventional one. What about the cross-linking to the thin corneas? We have patients, they have thin cornea, less than 400 micron of minimum stromal thickness, and they are still happy with their vision. They just don't need any more progression. They don't need any invasive surgery like PKP or DOLC or rings, but you cannot do cross-linking for them. Nowadays, I've came across with the recent studies that they do cross-linking for a minimum stromal thickness of 350, and actually myself, I started to do 350 minimum and still without any problems, actually. And another method is doing a hypotonic riboflavin, which swells the cornea. If you have 350 and you do a hypotonic cornea, it swells up to 400 in cross-linking. But the problem is also it's not as effective because when it swells, you cross-link, for example, the tier 100 stroma, but then when the swelling goes away, then the cornea shrinks, and then you end up with only 50 micron of cross-linking into your stroma. So it's not going to be as effective. Another method is putting a contact lens on the cornea and do cross-linking. This is also the same thing. You actually cross-link the contact lens to the cornea. So the amount of the cross-linking that happens to the cornea is not too much, so it's not going to be as effective as the conventional way. However, there are new strategies advocated by Dr. Hafiz. Also, they try to disobey the Dresden protocol, which mentions you have to have a fixed amount of fluence. They say, what about if you don't have a fixed amount of fluence? For example, if you have a cornea, a very thin cornea, like 300 micron, what if we just try to cross-link only the 70 microns and then stop wherever the fluence is? So this is the idea. This is under study, actually. So they try to stop whenever you have 70 micron of cross-linking, wherever the fluence is, doesn't matter. So it doesn't have to be a 5.4 fluence. So this is changing the strategy, actually, and coming up with a new nomogram. Finally, we come up with we talk about the complications of the cross-linking. It's actually a safe procedure in general, but there are still complications with cross-linking. The main thing is the iffy off is delayed epithelial healing. I would say infectious keratitis is not common, actually. Wherever you see a keratitis after cross-linking, think about immune keratitis or herpes simplex keratitis, because we know nowadays cross-linking is used for infection, for bacterial and fungal keratitis. It actually kills the bacteria and fungus. So infectious keratitis after corneal cross-linking is not that common. Whenever you see infectious keratitis, think about herpes, either a new herpes or a reactivation of undiagnosed previous herpes. Herpes simplex keratitis, or immune or steroid keratitis, which is much more common actually. And another complication is scarring. Just like I mentioned, I've found a lot of scarring happens with the conventional way after 1 year of cross-linking. Finally, the late onset immune peripheral keratitis, how I call it, actually this is not reported before. I'm collecting patients, until now probably 10 patients. This is something very interesting actually. The patients after uneventful cross-linking, you do cross-linking, the patient goes on after 3 months, 4 months after the cross-linking, comes back with the pain, redness, irritation in their eyes, and you see that there is an infiltrate at the junction between the cross-linked area and uncross-linked area. And this is only response to potent steroids. And it involves both eyes, each at a time, not together, and it's recurrent. As birth, I have a patient actually it recurs maybe 10 times. And every 3 months, every 4 months, it comes back pain. You have to actually use potent steroids like Predforte, and then they get better, and it comes back again. It's very this is a picture of one of our patients. If you see, there is infiltrate in the periphery. This is the area between the non-treated and treated area. It's just like an infiltrate. There's small liquid defects in the fluorescein area, and they only respond to steroids and comes back again. It's usually recurrent and bilateral. This is another patient, the same thing, responds to steroids, and actually I'm planning to report this. This is not immune keratitis because in periphery, presentation. Thank you very much for your attention. Nowadays, in the time of Corona, you don't shake hands.
Thank you very much, Dr. Vidal, for this nice presentation.
Thank you, Victor.
Quick questions, just 2 questions, because we are running out of time. I will, Dr. Sarah, she wants to ask you.
Yes, Dr. Sarah.
Thank you, Dr. Vidal.
Yes.
I want to ask you, I actually don't get your message to do cross-link EP on or EP off, and why do you prefer the technique, whatever do you prefer?
I prefer.
The pathophysiology is very complicated, and I can't get it.
Yes, regarding the my preference, I leave it off because of the causes that I mentioned. The explanation, I said that the penetration of the riboflavin is not good with EPON, and also there is antioxidants in the epithelium that removes the oxygen species that you need for the cross-linking. Therefore, I prefer doing EP off for the good reason that I mentioned. Regarding pathophysiology, actually, when you have a weak bowman layer is a backbone for the cornea, for the strength of the cornea. When you have a weak bowman layer or a breaks in the bowman layer, the backbone is gone, then it becomes weak. So when you do cross-linking, you actually add the mechanical strength again to the cornea. Is that clear, Dr. Sarah?
Dr. Zaid Al-Adari?
Yes. Thank you, Doctor. Thank you for a nice illustrated updated presentation. I've got one question. What is the minimum thickness that should be cross-linked that we can say that we're on the safe side, that we will not expect further progression of keratoconus?
Yes, and the Dresden protocol, the conventional way is 400 micron after removing the epithelium. Okay, so 400 micron is the minimum thickness. However, nowadays there are studies they do up to
350 microns.
Okay, this is the last questions from my friend Dr. Rafa. Dr. Rafa, mic with you.
Assalamu alaikum.
Alaikum salam, Dr. Rafa.
Thank you very much for nice presentation, Dr. Dilar. Please, when you doing AP of cross-linking, put contact lens. Okay, when you start steroid after cross-linking.
Yeah, a very good question, Dr. Rafa. Actually, I start steroid right away because we are afraid of using steroid after cross-linking because we're afraid of the epithelial healing. The study showed that actually steroid doesn't affect the epithelial healing that much. The steroid affects the stromal healing. When you have a stromal defect, you don't use steroid because you get milk. But if you have an epithelial defect, it doesn't affect that much actually. I use a potent steroid right after the cross-linking, spread forte, every 4 hours and still gets healing in 4 days, 3 to 4 days.
Thank you very much.
Yes, and I taper it in 1 month.
Thank you very much.
You're welcome, sure.
Thank you very much, Dr. Dilar, for this nice presentations.
Sure.
Thank you very much.
Sure, thank you very much. Yeah.
And I would like to ask you to give us more presentations in the next few weeks, okay?
Sure, thank you very much, Dr. Mohammed. Thank you.
Yes, yes. I would like to welcome all of us to our superstar international speaker, Dr. Ahmed Assaf, Ustazi. Dr. Ahmed Assaf, he's a well-known surgeons and speaker. Dr. Ahmed, معانا?
Yes, can you hear me?
Yes, I can hear you.
Okay, so thank you very much, Dr. Mohammed, for the invitation. I would like just to share my screen right now.
We can hear you very well.
Okay, now. Suppose that you have the front, the title slide now. Is it available now for you?
Yes.
Okay. Okay, thank you very much for the invitation, Dr. Mohammed. This is the first time for me to present online, and actually it's very exciting experience for me, and to present while I'm in the summer house and with very casual with the short pants. Anyhow, so my talk, I'll talk to you about the double needle flange haptic IOL fixation, or the intrascleral fixation with the Yamani technique. As you know that there are several ways to fix the IOLs through the sclera. We have the Chariot method, which was originally published in 2007 by the German doctor, and this was modified later on by Amar with the very next year in 2008 and published by the well-known name glued IOL technique, which necessitates the formation of two flaps, the sclera flaps, to fix the IOL haptics underneath. So Yamani, which is the original surgeon, is called Chin Yamani. He published this method for intrascleral haptic fixation, and he got the video prize winner, the first video prize winner in Lisbon 2016, and he published the technique as the double needle flange haptics, or popularly known as the Yamani technique by the name of the surgeon, Chin Yamani. The idea is to just introduce a 30 gauge needle, 1.5 millimeter from the limbus in one side, and then after insertion of the three-piece IOL inside the anterior chamber, you can feed the leading haptic in one of the one needle, and then you have to introduce another needle 180 degrees apart, 1.5 millimeter from the limbus. You can use the shaft of this needle trying to manipulate the lens, as you can see in this animation, and trying to bring the trailing haptic just in line or in a direct opposition with the other needle, and feed the trailing haptic inside the other needle. So you have two needles, that's why it's double needle technique. And then you can externalize both haptics outside the sclera, and to avoid slippage of those haptics, you can just use the thermal cautery and make knobs on either end of the haptics, and then push again those haptics to be buried under the conjunctiva gingiva inside the scleral canal. So this is the idea of the technique. I'm going to talk to you about this technique and how to start, if you are interested in this technique in your practice. First of all, this is the checklist. If you are going to start the Yamani technique, this is the checklist or the prerequisite for the Yamani technique. These instruments must be available on the surgical tray every time you should go for the Yamani technique. First of all, you should use a horizontal marker to mark the 180 degree meridian. Of course, you should need an ink marker here. This is an ink marker. Caliber to mark 1.5 to 2 millimeters from the limbus according to your interest. And you can use two 30 gauge needles, but those needles, those needles are hypodermic needles. Those needles are not available in my region. So you can modify the technique and use the 28 or 27 gauge needle. You can use either 28 or 27. My personal preference is to use the 28 gauge needle. And you need 123 microforceps to feed the haptic inside one of the needles, and you should use a 3-piece IOL. The original technique, the Yamani technique, has described the technique with a 3-piece lens made by Nikon, and it's again you can use any 3-piece lens like the Zeiss Lucia, but those lenses are not available in my region again, so I prefer to use the 3-piece IOL, which the code is coded by AR40E. I don't have any financial interest in any of these subjects mentioned in this talk, by the way. And you need infusion cannula. You have to fix infusion cannula inside the anterior chamber of the eye or the posterior chamber of the eye if the eye is vitrectomized, because you have to keep the eyeball most of the time inflated and pressurized. And of course, by the end of the surgery, you need to have a thermal cautery, just regular disposable thermal cautery. If one of these items is missed, do the manual electron. So mark part of the pupil, because this would be the reference mark for centration of the IOL. If you don't or skip this, you can still do the technique, but probably you expose or you might get a higher incidence of IOL decentration. So the best way to start is to start with the centration of the pupil with the marker, and then you can mark the 180 degrees accordingly. This mark, by the way, this is a flap marker made by Asheville. This is for Mastel, or sorry, Epsilon company. And this mark is designed mainly for the flap markers of the glued IOL technique. But I got benefit using these marks just to mark the site of entry of the needle and the site of exit or the site of entrance inside the eye. So I will show you in a moment how can you use benefits of these two marks on either side. Anyhow, you can just use 180 degrees marks of any model or any company. So again, this mark is centered on the center of the pupil. So start with the centration of the center of the pupil, and then you should mark the 180 marker available in your hands. And now you can start your surgery. This is the infusion cannula. You should fix the infusion cannula and turn the infusion on. So keep the eye pressurized most of the time. And now this is the 28 gauge needle. You can just bend it 120 degrees. It should not be 90 degrees exactly. Just keep it a little bit obtuse angle because it will be better for handling. And now this is the incision for the implantation, because this eye was already vitrectomized and aphakic. So the incision, the lens should go through 2.8 millimeter incision. So this keratome was 2.2 millimeter incision. I had to just little bit winding the main incision to make sure that the lens can fit inside can go through the incision. And now this is the caliper to make sure to mark where is my the needle will go, 1.5 millimeter from the limbus or 2 millimeter from the limbus. I prefer 1.5 millimeter from the limbus, and you have to make 2 paracenteses. Make sure now that actually this is the main incision and this is the horizontal marks. Try to keep it 90 degrees apart. So the main incision will be 90 degrees according to this mark here and 90 degrees according to the other mark on the other side. And on either side of the main incision, you can do 2 paracenteses to aid for fixation of the haptics. Now, this is the 3-piece lens. You can use any 3-piece lens available, but I would prefer to start with the sensor or Lucia of Zeiss if available in your country or your region. And now this is the side of the needle here. It will start and go through the sclera this way, and then will get inside the posterior chamber of the eye, just in front of the other mark. That's how can we use the flap marker here, because the flap marker can mark the side of the entry just through the sclera and the side of entry inside the eye, just opposite to the other mark in one side. So again, you can see this is the needle here, and now with the microforceps through one of the paracenteses, you can feed the leading haptic inside the needle here. This is a not very difficult step. The most tedious part of the surgery is feeding of the trailing haptic inside the other needle. So now introduce the trailing haptic inside the anterior chamber. It's better to keep the pupil mid-dilated. It's not essential to be very dilated, very well dilated, otherwise the lens will hang in the posterior segment of the eye. And now through the other paracentesis, you can now feed the trailing haptic through the needle. This is the most difficult part of the surgery, and it might take you a few moments until you succeed to feed the trailing haptic inside the needle. As a rule of thumb, try as much as you can to keep both the needle and the trailing haptic just in one side, in one line, as this way, in one line. Because if you don't do this, you might damage the haptic, you might kink the haptic. So try as much as you can to keep the trailing haptic and the other needle in one line this way, and this way you can just feed the trailing haptic with ease into the other 28 or 30 gauge needle if available in your region. Now just for a few millimeters, and now try to externalize both haptics at the same time. Try as much as you can. Try to pull on the both needles at the same time, and you can see that the lens will take its position just behind the iris. And now this one haptic here, and this is the other haptic here. You have to secure this haptic because there is high incidence of slipping of the lens if you didn't secure the other haptic with the MacPherson. So you have to secure both haptics with the MacPherson until the it's got its resting position. And then this is the most interesting part of the surgery, just to make the knob and try to make the knob large enough to avoid slippage of the haptics into the sclera. And you have to make sure that the both haptics has already been buried inside the scleral canal underneath the conjunctiva. Don't leave the haptics exposed over the conjunctiva or just beneath the conjunctiva, because they might erode the conjunctiva in the near future. So just make sure that the haptics are already buried inside the scleral canal before conclusion of this surgery. So this is as a description of the Yamani technique. And now we can get some key points here. First of all, you have to mark the center of the pupil in the very beginning of every surgery, because you can, as I mentioned before, you can skip this step, but otherwise you might get a high incidence of lens decentration. So here you have to mark the most central part of the pupil. Otherwise, if you didn't mark the central part of the pupil, you might get decentration of the lens. The second, the side of the needle insertion should be exactly 180 degrees apart. This is the value of the 180 degrees marking. Don't try to guess. Don't try to keep it around 100. No, it should be precisely 180 degrees apart. The side of the inlet and exit on the other side should be 180 degrees apart. You may dissect the conjunctiva once necessary. I will show you in a moment. And you have to secure both haptics with McPherson forceps and avoid stress on the haptics. I will just go in details for these points. We already discussed the centration of the pupil, or marking the pupil. And this is the second key point here, is that the needle insertion on either side, the needle insertion of this side and the needle insertion on the other side should be 180 degrees apart. And this is the value of the 180 degrees marker of the that we have to use in the very beginning of the surgery. Again, you may dissect the conjunctiva, although the technique is very elegant that you can fix the IOL without dissection of the conjunctiva, without cautery, without using glue, without making a sclera flaps. But sometimes you have to dissect the conjunctiva. You can see in this movie, you can see that the conjunctiva is getting ballooned, most probably because of the egress of the fluid around the needle, around the 28 gauge needle. Sometimes there is fluid coming around this needle into the scleral canal, causing the conjunctival ballooning. You can see this is the one haptic here. I have succeeded to secure this haptic, and the conjunctiva is ballooned in the other side. You can see the conjunctiva is very well ballooned. Okay, I tried to secure this haptic, but I failed. You can see now the haptic has been slipped inside the posterior segment of the eye, and now I'm in trouble because I didn't dissect the conjunctiva. The conjunctiva is ballooned and masked the haptic, so I couldn't retrieve the haptic or fix the haptic before slipping inside the eye and before making the knob with the thermal cautery. So you can dissect the conjunctiva if you notice some conjunctival ballooning in some cases. Again, you can dissect the conjunctiva in other cases, of especially in elder people, elder people, because especially if they have blood thinners like the aspirin, you can see here, I learned from the first case that I have to dissect the conjunctiva because this pooling of the subconjunctival hemorrhage will obscure the trailing haptic, so I will not see this trailing haptic once externalized. So this may get in trouble, so it's preferable to dissect the conjunctiva, do some on the sclera, and then retrieve the haptic under direct visualization here. As you can see here, this is one haptic. There is no problem in this side, in the left side, but in the right side, you can see it, just section of the conjunctiva and quarter of the sclera, and I could secure the case and avoid slippage of the lens like the other case with the conjunctival ballooning. And you can see here, the fourth point is to secure the haptics with McPherson forceps. You can see here, now this one haptic has been externalized and the other haptic has been externalized. I should get a McPherson very quickly to secure this haptic, and you can see the haptic is already slipped inside the eye before have the chance to secure this haptic before slippage inside the eye. So you should, once externalize, secure both haptics with 2 McPherson immediately. Don't leave a second intervening between the 2 steps. So in this case, I had to again feed the trailing haptic into the needle and trying to retrieve this haptic. The pupil is getting down and the surgery has become more complicated. So I had to use the iris hooks and try to dilate the pupil. And again, I could retrieve the haptic again after conjunctival dissection and secure these haptics, both haptics in place. So you can overcome the some fallacies with the technique, but it's preferred to follow the steps. Otherwise, you will get some complications. Of course, I'm sure they can get over these complications, but it's better to avoid it in the very beginning. So you can just dissect the conjunctiva. You should secure both haptics with the McPherson and dissect the conjunctiva when necessary. If there is any conjunctival ballooning, which is very common in children, or if there is subconjunctival hemorrhage because of the site of the entry of the needle might cause subconjunctival hemorrhage, especially in elderly with blood thinners. And finally, try to avoid stress on the haptics of the IOL by 3 main factors. First of all, you have to keep the positional relationship of the wound. I will discuss it later on. And you have to use two, not one, two needle. That's why the technique is called double needle. And take care about the insertion angle of the needle through the sclera of the eye. So this is animation will show the positional relationship between the main wound, as I mentioned before in the very beginning of this presentation, that the main wound should be in relation of 90 degrees with the side of the entry of this needle, and the side of entry of the other needle should be 90 degrees apart exactly. And that's why you should mark the eye in the very beginning. The second is you have to use the 20 gauge, two 20 gauge needle, or two 27 gauge needle, or two 30 gauge needle. Anyway, you have to use double needles, not one needle, because some surgeons prefer externalize one haptic, and then after externalization, remove the needle, and then use the same needle for externalization of the other haptic. This will cause the lens to rotate counterclockwise and making feeding of the trailing haptic much more difficult than using the two needles. So you can use just the two needle, one needle. If you can just externalize one needle, this lens will rotate counterclockwise, and then trying now to feed the trailing haptic with the other needle, with the same needle, you can't. So it's better to use two needles, one needle for the trailing haptic, and keep it inside the posterior chamber of the eye. Don't worry, it won't hurt the ciliary body, it won't hurt the retina, it's away from the retina, and make sure that the tip of the needle is already occupied by the haptic, so the haptic of the lens, so it won't hurt the intraocular structure. And then use the other needle for the trailing haptic. So use double needle, not one needle. Insertion angle, which is quite difficult to guess or to do it by your hand. It's a matter of experience. Try as much as you can that the angle of the insertion of the needle should be about 20 degrees to the limbus, 20 degrees to the limbus here, and about 5 degrees with the iris plane to cope with the angulation of the haptics of the three-piece lens. It's quite difficult, but it's a matter of training. But anyhow, if you didn't if just not 5 degrees, just came at 10 degrees or 0 degrees, it won't make too much or significant difference in the surgery, or it won't affect the results to that significant. So anyhow, try as much as you can to keep the angulation of the needle about 5 degrees with the iris plane and about 20 degrees with the limbus. This way, you will not induce too much stress on the haptics, and you make sure that the lens won't be tilted and won't be decentered with the Yamani technique. I think I have concluded my presentation nowadays, and I'm ready for any questions.
Thank you very much for this nice presentation, Dr. Ahmed.
This is wonderful presentation.
Thank you very much.
Thank you, Dr. Essa. Just one comment. The first needle that you entered with, does somebody hold that needle for you, or it just stays there?
No, it stays there. A very excellent question. There is no, you don't need third hand with you. This is one of the advantages of the Yamani technique. Sometimes with the glued IOL, you might need assistance from the nurse or from other doctor. So just leave the needle, lay it on the sclera, and leave it inside the eye. Don't worry.
Thank you.
So any other questions for Dr. Ahmed? Okay, we will take Dr. Ahmed Kinawi. Dr. Ahmed.
Hello, Doctor. Hello.
Okay.
Dr. Ahmed Asaf, can you hear me?
Yes, of course.
Okay, thank you, sir, for the marvelous presentation. I have one question about the first needle after you engage the haptic. Do you push it inside the eye a little bit to rotate the lens, or just hanging there?
The first needle you can see here in this movie here. You can see, your question is about the first needle, right?
Yes,
so
yes.
Here you can see that now I'm feeding here.
Yes.
For a few millimeters, and then push it little bit inside the eye. You can push it little bit inside the eye, so you can manipulate the lens trying to bring the trailing haptic in line with the other needle. So you can see this, I'm not holding the needle this on the other side. You can see I have two hands here, and the needle here is not lying on the sclera here, and almost pushed until the angulation inside the eye. So I hope this answers your question.
Yes, it does. Thank you.
Okay, we will take Dr. Munib Alam. Dr. Munib. Dr. Munib, unmute yourself.
1 second. Yeah, hello, Dr. Asaf. Can you hear me?
Yes, of course.
Yes. Actually, I just had two questions to ask you. The first question was that once you engage the haptic in the 28 gauge needle, what precaution do you need to take that it doesn't slip out of the needle once you're taking it out? Is there any precaution to take, or it will stay in the cavity?
Do you mean the first needle?
Yes, yes. Once you engage inside the the 28 gauge,
yes,
and then you
can engage it for 2-3 millimeters. So this way you are sure that the needle won't slip, the haptic won't slip from the needle. The other factor that I use the 28 gauge needle, not 27, because 28 has a tighter pole, so it will hold the haptic inside the lumen and secure the lumen inside the haptic of the needle. That's why I prefer the 28, not 27.
Okay, and one more question: that once you coagulate the tip of the haptic, how secure is it, and how much coagulation do you need to do of the tip of the haptic outside?
Very good question. The tip of the haptic should be rounded, and it depends upon the distance between the thermal cautery and the haptic. So you have to be very close to the haptic, but don't just keep the thermal cautery about 0.5 millimeter from the tip of the haptic exactly, and the transmitted heat through air will make the knob. The knob should be around 1.5 millimeters. Should be around 1.5 millimeter. This way you are sure that the knob won't allow the haptic to slip inside the eye.
Okay, thank you very much, Asaf. Very good presentation. Thank you very much.
Thank you very much.
Also, Dr. Rasha. دكتورة رشا موسى معانا. دكتورة رشا. دكتورة رشا.
دكتور توفيق.
اتفضلي يا فندم.
Hello, Dr. Asaf. It's very nice presentation.
Thank you.
You made it very easy. I have two questions. It's not like that easy. First of all, why you choose to put it 1.5, not 2 millimeter from the limbus? And whether the point of entry also 2 millimeter or 1.5 millimeter from the side of from the incision. This is the question. And what's the minimum age you put Yamani? And whether you have faced cases, I have a couple of cases, we have some uveitis after the surgery. Whether it is while I don't have any with the regular either glued IOL or with sutures. Did you face this problem?
Answer the first question about 1.5 millimeter or 2 millimeters, then you can repeat the other question again because I'm confused. Yeah, so. Why do I prefer 1.5 millimeter? Because it allows me to externalize larger parts of the haptics. When you get larger parts or longer parts of the haptics externalized, you can manipulate the centration of the lens. You can even deduct, you can even shorten one haptic if you get, in one case, if you get some decentration of the lens, you can shorten one haptic on one side and keep the other haptic intact. So this allows me to manipulate the centration of the lens. Because if the further you are going away from the limbus, the sclera now is getting further apart, and the amount of the haptics or the length of the haptic to be externalized will be lower. So 1.5 millimeter is enough for me. This is the sweet spot. If you are getting closer to the limbus, you might get optic capture by the iris. So 1.5 is the sweet spot. The further you are going from the limbus, the less amount of the haptic to be externalized, and this is very critical for you. And the closer to the haptic, you have a larger amount for the haptics to be externalized, but you have high incidence of optic capture with the iris, with the pupil of the lens. So I hope this answers your first question.
Yes.
Okay,
The
what
other
about
part,
another one?
what's the minimum age you put Yamani? It's a very good option for children for pediatric and treatment of aphakia. What's the smallest age you put Yamani?
Yes, I have put Yamani for the youngest patient about 4 years old. I didn't have the chance to put Yamani for a younger than this, but if I have, I would do. But as a trick, make sure that these patients have high incidence of conjunctival ballooning, and the sclera is very, very elastic. So because the infusion cannula will infuse the eyeball, and the eyeball will be pressurized, sometimes the eyeball, like a balloon, will be larger than it is. And this carries the high incidence of slippage of the haptics inside the posterior segment. So in these cases, in the very beginning, I'll dissect the conjunctiva on either side to externalize both haptics on either side under direct visualization under the sclera itself. Under the conjunctiva, just retract the conjunctiva, make some cauterization of the sclera, and then I will externalize the haptics through the sclera with direct visualization. So this is the trick I have learned from my mistakes in these patients. The pediatric patients, the tenos capsule is very thick, the conjunctiva is thick, and the sclera is thick and elastic as well. So I would prefer to dissect the conjunctiva on other side. And the minimum age, in response to your question, is 4 years. If I have the chance to put it in 2 years, I will do.
Okay.
Thank you.
Thank you, Dr. Ashraf. Thank you very much for you. And we're waiting for a presentation next week, inshallah. Now we will go to this is the last question, Dr. Zana. Dr. Zana? Dr. Zana, unmute yourself.
Hello. Thank you, Dr. Ashraf, for the nice presentation. Thank you, Dr. Tawfiq.
You're welcome.
I have one question. Just I want to know from your practice, daily practice for this technique, is it what is the usual for your daily practice? Is to cut or shorten the haptics, or you leave the haptics as it is and just cauterize? And when do you like to cut and shorten the haptics? Thank you very much.
Okay, as a routine, I don't cut the haptics. As a routine, I just keep the haptics and then just make the cauterization. And in this, you can see in this photo, if you want to cauterize the haptic, you can hold the haptic about 2 millimeters from its tip with a McPherson. So to make sure after cauterization or after making the knob on either side, you have the same amount or the same length of haptic on either side. So you have to just hold the haptic about 2 millimeters from its tip in this side, and you have to do the same on the other side. And I don't cut or trim the haptics, let's say, in every case. I just do trimming of the haptics if I have, just before conclusion of the surgery. When I'm going to introduce both haptics inside the eye, I will notice there is some decentration of the IOL optics, so I will externalize one of haptics on one side. I'm trying to trim it and then make another cauterization, and I will do the same maneuvers on either side until I have perfect centration of the lens. So I'm doing the trimming of the haptics just if in case I have decentration of the IOL.
Okay, thank you very much, Dr. Ahmed, for this nice presentation, amazing presentation. I know you are now in your holiday, so enjoy your holiday, and I wish you to stay safe, inshallah.
Thank you very much, Dr. Muhammad, and this is a very exciting experience. I'm glad to be part of this meeting, and I'm glad by the questions from my colleagues, and I'm looking forward for another presentation in another meeting soon, inshallah.
Thank you very much. Of course, it's our honor, sir. It's our honor, sir. Thank you very much.
Thank you.
Now, dear colleagues, we move to the last presentation. I'm sorry, it's going quite long meeting today.